All right, good morning. I'd like to welcome everybody to our conference today, titled the 4th Annual Rhode Island Substance Exposed Newborns Conference, Building Bridges to Support Families Affected by Prenatal Substance Use. I am Christy Wickham from the Rhode Island Family Visiting Program at the Rhode Island Department of Health in the Office of Family Visiting. I will be going over some information and housekeeping items about today's conference. I'm hoping everyone has had a great start to this morning. I know I did with walking my big kindergarten to school and back. Alrighty, so this conference is brought to you by a collaborative effort between the New England Addiction Technology Transfer Center, the Rhode Island Department of Health, the Substance Use and Mental Health Leadership Council of Rhode Island, the Department of Behavioral Health Care, Developmental Disabilities and Hospitals, the Rhode Island Department of Children, Youth and Families, and the Rhode Island College School of Nursing. Alrighty, and if this is your first Zoom webinar, take a moment to become familiar with the Zoom webinar controls at the bottom of your screen. Please note the Q&A and chat buttons. You can submit your topic-related questions for our presenters at any time during the presentation using the Q&A option. I'll be monitoring the Q&A box and sharing questions throughout or at the end of the presentation. Feel free to post questions or comments you have throughout the presentation, and we will do our best to answer them accordingly and as time allows. This webinar is being recorded, so all attendees are automatically muted and their videos are turned off during the entire conference. The chat feature should be used to communicate additional information such as relevant resources, topic-related comments, and for technical support. And attendees who registered and attended this conference will receive an email within the next week before December 8th with an evaluation link and a certificate of completion containing your CEUs. Additionally, we want to make sure everyone is aware, slides will be available following the conference. And with that, I will pass it along to my colleague, Margo Katz.
Good morning, everybody. Thank you for joining us. I'm Margo Katz from the Rhode Island Department of Health. I just want to let you know that we have a slight change in the speaker lineup today. Our dear friend and colleague, Lori Dorsey, had to withdraw from the conference. She does send her profuse apologies, and we are sending her lots of love and light. Ray, can you, before we start, pull up the first poll? We'd like to get a feel for who is in the room. And while Ray does that, I'm going to introduce Deborah Garneau. Deb is the Maternal Child Health Director in the Division of Community Health and Equity at the Rhode Island Department of Health. Deb's commitment to underserved women, children, and families is evidenced by her compassion and tireless advocacy to eliminate health disparities, increase access to quality health care, and address social and environmental determinants of health. Deb?
Thank you, Margo. Good morning, everyone, and welcome. This is a great audience. We have like 130 people already on the line with us, and so that's very exciting for this very important topic. So on behalf of Director Alexander Scott and the Rhode Island Department of Health, I want to welcome you all. The conference planners have put together an informative and very timely program for you this afternoon. So I'd like to welcome you and invite you to fully participate. Sometimes the virtual format provides an opportunity for more people to participate, but it also gives us an opportunity to be more distracted. So I'd like to invite you to stay engaged and resist the temptation to multitask. So this conference, now in its 4th year, is a model of cross-disciplinary collaboration. Rhode Island state departments, higher education, substance use, and mental health organizations have all come together to support the wide array of providers who care for pregnant and parenting families with substance-exposed newborns. The importance of coming together as a community of like-minded people with shared goals cannot be overstated, but it's not always realized. Despite being a small state with an abundance of supports and services, we are missing opportunities for collaboration, opportunities that can help support optimal health and well-being for substance-exposed newborns and their families. I have no doubt that you will learn a lot from today's presenters. Again, I invite you to press into that learning and to take full advantage of this opportunity to hear from and engage with Rhode Island's experts. In addition, I encourage you in the next few days, weeks, months to come to reach out to other providers and professionals in your community who work with the same individuals and families that you serve. This will ensure that Rhode Islanders benefit from the strong and collaborative relationship between providers. And we know that this leads to healthier Rhode Islanders and a more fulfilled provider workforce. So welcome everyone, and thank you for being here.
Thank you so much, Deb. You're a great boss. And I value, you've taught me so much since I've been at the department. Ray, can you pull up the results of the first poll? I just want to see who we have here. It looks, oh, nice. Okay, I got to scroll down. It looks like substance use, treatment and recovery wins the day. And a bunch of others. This is terrific. I'm thrilled that we were able to bring everybody together. So I built a really tight schedule, everyone. So we're gonna roll right into it. I'm gonna introduce our keynote speaker, Sharon Morello. Sharon is a nurse who's worked in all levels of care for the treatment of substance use disorders and mental health. In her more than 40-year behavioral health career, Sharon has established behavioral health programs in acute care hospitals, directed care in outpatient settings, served as the nursing director for opioid treatment programs, and most recently was a technical expert for HRSA's rural community response grantees across the country. Sharon is a certified NIDA trainer for buprenorphine. She teaches at the New England Institute for Addiction Studies. She's a longtime trainer for Rhode Island Substance Use and Mental Health Leadership Council, having trained over 1,000 Rhode Island nurses in treatment of opioid use disorder. Sharon has worked as the state methadone authority for the state of Rhode Island, helped to open the first recovery center in the state, helped to establish the first methadone treatment of incarcerated pregnant women in Rhode Island, and had a hand in forming Rhode Island's first drug court. We are indeed lucky to have her in our little state. Sharon?
Thank you, Margo. I'm going to share my screen. There we go. All right. So thank you, Margo. That was a very nice introduction. I'm so happy to be here. This is the fourth one we've had. And of course, last year we didn't get together to do this, but we are here now. So thank you very much for inviting me. And I'm thrilled to be here to share anything I can with you. It's important for you as we go along to put in the Q&A. If you have a question as we go, please don't wait till the end. It really makes for good interaction. I know we're on a tight timeline, but we'll stay on track as best we can. So what are we going to cover today is really important. I'm going to go over some background information and scope of the problem. Most of my information is going to be pretty much at a higher national level. And I know that Margo's going to present later at more drill down as to what Rhode Island might actually look like. We can't really talk about this whole topic without talking about stigma. Since 1985, I've been talking about it, and I wish we've gotten rid of it, but we haven't yet so far. So we still need to continue to work on that, and I'll mention that a bit as we go. It's always an underlying theme. And then a bit about the brain and substance use disorder in itself, because unless we really understand this disease from the science perspective and a neurobiology perspective, it's going to be difficult for us to get rid of the stigma and understand what's happening with the people that we serve. And this has been an area that has been not as addressed as it should be. And then we need to talk about evidence-based practices and the use of medications specifically for opiate use disorder. And at the end of the day, if we don't do universal screening and develop these partner collaborations, we can't do all the other work either. So it all works together. So what's the background and the scope of the problem, some of the data and the things that we know, and then what are some of the barriers to problem solving and barriers to care and the problem of stigma getting in the way? We talk about opiate use disorder, but we're not just talking about that. We're talking about all substances of use. And pregnant women with opiate use disorders do not just always use opiates. They may use a lot of other substances as well. And some women don't use opiates and use these other things that you can see. Frequently used substances, alcohol, benzodiazepines, cannabis is on the rise. Tobacco is still gigantic. In fact, most women who have a substance use disorder also smoke. So we have to look at all those things as we look at them. Each one of these substances of use can have different kind of adverse outcomes for the mom and the baby. Low birth weight, more severe NAS and some others, and then potential developmental delays, not as related to a particular thing, but all of them together. So when we look at alcohol or some of the newest research that's coming out on cannabis, showing some real outcomes that we need to continue to watch as we look at child development going forward, and not just the NAS period. So when we look at this, some of the other data we're seeing is that there's been an increase in opiate use disorder among pregnant women in all the states. And we see that about 6.5 per 1,000 women have an opiate use disorder at delivery. Pregnant women who took opiates for non-medical uses were more likely than non-pregnant women to obtain opiates from their doctors. Interesting statistic. And there has also been a sustained increase in both maternal OUD and NAS diagnosis among rural residents. So this is something that we're beginning to see. And, you know, in Rhode Island, we don't really have an identified rural area, but in other parts of the country, that's the case. I also want to say, when we're talking about statistics and data across the country, it's a difficult topic because not all areas of the country collect data, I can tell you, as good as we do here in Rhode Island. We have some great data collection. We have current data collection. We can get information quickly at our fingertips. That doesn't happen across the country. And many times when we're looking at data that the CDC is taking in for the whole country, I think we're really looking at numbers that are way under what they really are. So we look at this kind of information, we know that we've got use among all kinds of substances. Opiates are not the only ones. And you can see here that tobacco and alcohol are the top ones. And this data only goes to 2018 because getting this kind of national data at our fingertips as quickly as we get it at state is the best that we can do. This is low. We know that these are low. If this is national, then we're not getting the full report. I worked in some rural states and counties where there's no collection of information at all. So we know those states are struggling with the same things that we're struggling with. So these numbers are here, what they are. I don't think we need to look at them individually, but recognize tobacco and alcohol are still way up there in use. When we talk about overdose in pregnancy, it has been a huge issue across the country this past year. We know that we've had more overdoses in the country this year than we've ever had before. We made significant strides here in Rhode Island 2 or 3 years ago to really start to decrease those numbers. And with the pandemic, it has really put a glitch in the progress that we've been making. I can't imagine what our numbers would be had we not done some of the interventions that we've done. So I'm thinking that even though the numbers may be up this year, I think had we not been where we were before the pandemic started, we'd been even in worse shape. According to one study, 14% of pregnant women reported a non-fatal overdose in the past year. This goes back to 1918, not 19. This isn't 20 or 21. So looking at that national data takes us back a couple of years. Younger age women were more at risk than older people as we looked at the study. And participants had received opiate overdose education and naloxone. So that was a good thing. Another study found that the risk of overdose was 4 times higher in postpartum period than in the 3rd trimester. And we'll talk a little bit about the 4th trimester in a little bit. The risk of overdose was highest from the period 7 to 12 months postpartum. And we've now identified that as the 4th trimester.
Sharon, really quickly, A question came in and I'm not sure what part of the presentation you're going to be speaking about this, but
Okay,
at some point, will you be able to share info about cannabis use during pregnancy?
I can share a little bit out of it. It's just coming out, but I'll try to touch base on it.
Wonderful, thank you.
Yeah, thank you. Estimated numbers of infants affected by prenatal exposure. We looked at these numbers in this way. Look at this data. This is 2017, and this is not bad. Getting this data at 2017 coming in from the Center for Behavioral Statistics and Quality, which gathers this information. And I always try to make sure that I've got the most current, and this is the best that we could find right today. So we're looking at potentially affected prenatal exposure. You can see alcohol hits the top. Tobacco is at the top. I know our conversations gather around opiate use disorder. We have some really good treatment for opiate use disorder, and we have good treatment for other things as well, but we're not focusing on, I think, as much as sometimes we should. And we know that alcohol is still second, and when we include illicit substances, which including all of them. And then let me just touch on binge drinking and heavy drinking as it relates different to alcohol use. Binge drinking is identified as a woman or a man who drinks between 3 to 5 drinks in a short period of time, say 2 to 3 hours, to get their alcohol level over 0.8. That's binge drinking. And we have a large range of people who do that. The biggest age group is between 25 and 35 for the most of binge drinking. That happens. Heavy drinking would then be considered what would be more of a moderate to severe alcohol use disorder. And alcohol use is random use. So it's not considered binge drinking or an alcohol use disorder. And then the withdrawal symptoms we see by NAS, which is the neonatal abstinence syndrome. We're focusing specifically not just on opiates here, but all NAS, because that's what that would be. And then the fetal alcohol syndrome we see as these births here. So we're still looking at the national data. This is the most we've got, and this takes us back to 2017. So there's a lot of things that, interfere with how an infant is affected in prenatal exposure to substances. It's not just the substance itself, but all of the pieces that come into play. We've got family characteristics and genetics. We've got family internal things of trauma. We'll talk a little bit more about trauma as we go. What kind of prenatal care has happened during this time? Exposure to multiple substances, alcohol and tobacco as well, not just the illicit substances that we sometimes discuss. And then early childhood experiences, bonding with parents and caregivers, which we talk about, and other health and psychosocial factors. So all these things come into play as intervening and affecting the prenatal exposure to substances and how that impacts the neonate and the family. So women, specifically in OUD, we know that women experience a faster onset than progression of OUD than men. We don't exactly know what the genetics is or the DNA around that, as it's specific to women, slightly different. We even know that happens with women who are drinking alcohol, that their alcohol, they get have medical comorbidity, things that happen with their alcohol use earlier than men. If I see a person who is going to have end of liver disease or end of stage liver disease for their alcoholism, I can see it. If it's a woman, she's going to be in her late 40s. If it's a man, he's going to be in his late 60s. For some reason, they really get impacted differently by alcohol intake. Not sure of all the genetics and the science around that, but we know it's a fact. Women experience greater impairment in social and occupational function than men often do, and women are less likely to engage in treatment than men. What are the reasons for that? A lot of them. Women who are parents and families, caregivers, face additional barriers to treatment. There's a lot of stigma as it comes to this, and it increases when you're the caregiver of a child, whether you're a man or a woman. That stigma is going to increase in that place. Women are more likely than men to experience chronic pain also, and have a tendency to use prescription opiate pain medications for longer periods of time and higher doses over a period of time. We see more women prescription opioid dependent than we see in men. Psychologically and emotional stress have been identified as risk factors for hazardous prescription opioid use among women, but not as much in men. So the science is telling us this is a population that is more problem prone, more vulnerable into developing an issue specifically around opiates. Women tend to use substances differently than men do as well, and sometimes using a smaller amount of a drug and a shorter amount of time actually can cause a quick dependence. It's called telescoping, and this happens more likely in women than in men. As healthcare givers, wherever we're working in the field, if we're coming in contact with people to work with them, to help them, because they're walking in our door, wherever that door may be, primary care practice, OBGYN, pediatrician's office, a quick urgent care, anywhere we go, we have to be healthcare workers who need to change the tide of this epidemic. And if we're not all on board to do that, it's not going to work for us. How do we get there? We need to decrease the stigma. In 1985, I started to work in a methadone clinic. It was called a methadone clinic. Then we call it OTPs today, opiate treatment programs. And I got into the work in that program. I didn't know a thing about it. The patients taught me half of everything I ever learned. And at the end of the day, I said, oh my goodness, people are getting so much better with this medication. Things are working, it's getting better. But the stigma is just unbelievable. So how do I know what will happen? We'll get the science, we'll teach the science, we'll prove the science, we'll get the research, we'll share it all, and the stigma will go away because it just makes sense. But we're sitting here in 2021 and that's still a struggle. So we need to think about decreasing stigma, increasing access to evidence-based care, including medications. We've known since the mid-80s that methadone was an effective medication for the treatment of this chronic disease, and yet we still don't use it as an evidence-based treatment. Supporting expansion of naloxone is essential, especially in other parts of the country. We're good at it here in Rhode Island, but that's not the case everywhere, and people still believe that we're enabling people by giving them that medication. But the last time I checked, treatment's not going to be effective unless you've got a pulse and I've got you sitting in front of me. So, and you're a person who finds your pathway to recovery, right? And then we need to recognize and provide screening, brief intervention, and referral to treatment. Like all other chronic diseases that can actually cause death and injury, we try very, very early on to see who's vulnerable and prevent the disease. And then if we do the screening, we actually then can do an early intervention to prevent chronicity. But here, we don't do universal screening. We're not looking at all those things. We're not doing early interventions. We're waiting for things to happen and become chronic. And that's not the way we treat disease for any other disease. And we need to think about how we do screening, brief intervention, and referral to treatment early, and universal.
Sharon, a quick clarification question came in case others are preparing to ask the same question.
Yep.
When you say women, are you meaning that people who are assigned female at birth?
Yes.
Okay. I figured that. Just wanted to make sure.
Yes. Yes. So that would be that would be my answer. Because that's where the research is coming from right now.
Perfect.
Any
Thank
other?
you.
Okay.
Nope, that was it.
Okay. Reducing stigma among professionals and people in the community. You know, in order for us to do that, the first thing we need to do is we need to know the facts, right? We can't just have feelings about it. So we'll talk a little bit about, you know, how you're going to do universal screening and how do you get your staff on board to be part of that. You need to know what your staff thinks. You're going to need to dig down to find out what are the attitudes of the people who work for you and how do they feel about it? Because you may be surprised to know that they have strong feelings that will get in the way of them being a participant in doing screening and checking and working with people in a trauma-informed way. So you need to be aware of your own attitudes and your behaviors. You need to choose your words carefully because language counts. And you need to educate others when you get a chance. And you need to focus on the positive because We need to know that, and we do know that people get into recovery and treatment can work. And some people can get into recovery without our help. And that's great. But focus on the positives so that we can move forward. So when we're dealing with stigma and bias, we need to think about it with our collaborative partners, always thinking about how we're going to get rid of that. I know this is a lot of information on this topic, but it is significant because if we don't get rid of some of this stuff, we're never going to get to early intervention, screening, and universal precaution screening. So that's what we need to think about. Language matters. We need to build relationships and trust with our partners. We need to demystify the process of treatment and recovery, including what has been called relapses. We need to humanize recovery. We need to celebrate and promote success. We need to identify partners for joint messaging and training. We're all doing things in duplication. We did this, we do that. Oh, I'm doing that too. Why can't we join together in partnerships, joint messaging, training, and enlist media advocates and opinion leaders, get people on board and address stigma from within. So all know what are the feelings of stigma in your own house, in your own shop, where you work every day. Knowing those things is important. I recently did, about 6 months ago, a survey of an agency that wanted to start doing some work with substance use patients, specifically providing them with Suboxone. And I did a survey with them to see, how they were going to do with that. And what are their feelings? What do they think? Are they pro treating people with substance use disorders, or are they feeling like that's not their job? Let somebody else do it. What are their feelings and what's their knowledge? And what I found out is that they had a lot of uncertain knowledge, but they had a lot of strong feelings. Once we educated a little bit, we could change that. But nobody thought that that was the case until they really checked and drilled down to see what's the stigma within your own organization and in your own shop, and how do people feel about it. I recognize that when we educate people on the brain and the science and the evidence base, and we give them black and white information that's clear and scientific, it changes how they think and what they're thinking. So education helps. It doesn't get rid of all the stigma. If somebody's strongly feeling the way they do, as much as I educate, I may not change their opinion. But I have to say, in all my years of doing that training, I've seen a lot of changes in people's thoughts by getting the right knowledge. So it's important. Once again, language matters. These things on the left side hurt. These things on the right side help. So we don't call people addicts or alcoholics. We call them the people with a substance use disorder. We used to, back in the day in the 80s, call the urine was a dirty urine or dirty screen. That's got a horrible connotation to it, right? So we talk slightly different today than we did back then, but people are still using this hurtful language on the left. We need to really emulate how we change the way we talk and use it slightly different. I mean, even to the point where I've heard people say the baby was born addicted. Well, babies are not addicted. They may be exposed to a substance, but they're not addicted babies. And so language matters. So there's a science of addiction that we know. It's a growing body of evidence, and that there's structural vulnerability of brains to certain intoxicating substances, and that we know that maybe there's a genetic component that's with it. And we're learning more and more about genetics and DNA mapping to see who's vulnerable, and that it's coming. It's not all there yet. The interesting thing about science and substance use disorders is that we can take the science and get the research, but we don't always bring it to the patient bedside or to where the clinician can implement it. It takes way too long to get science to where it needs to get, which is at the patient level or at the person level. But genetics is changing, and the genetic research is coming, and it's getting better, and we'll be learning more. What we do with that research then is the next issue. Early developmental issues and environmental factors play a huge role in the science of addiction. We know that people who have adverse childhood experiences under the age of 18 are are more vulnerable to mental health, substance use, and medical problems. So back in the 1990s, early 1990s, 94-ish, in San Diego, huge study, 5,000 people were studied. Unfortunate thing about the 5,000 people that were studied was that it was insured people in San Diego, 5,000 insured people in San Diego, which meant in 1992, 94, they were all white middle-class people. So what did that mean? So the study was done, it was 5,000 people. It was called the ACE Questionnaire. It was 10 questions. It's called Adverse Childhood Experiences. And the questions are, for the first 5 questions, under the age of 18, did these things happen to you? And the first 5 questions were related to sexual abuse, physical abuse, verbal abuse, and such. And then the last 5 questions were, did these things happen to you under the age of 18, but not to you, but to somebody you love? Was it your mother, your brother? If out of those 10 questions, you asked 4 of those questions with a yes, the chances of you developing mental health, substance use, or medical problems went up exponentially by 50 to 60%. And the more yes questions, the higher it went. That study was repeated across the country to thousands of people. Now, all cultures, all people, not just those white middle-class people in San Diego. And the repeated research for all peoples was that, yeah, the answer is this. We have a vulnerability tool. We can give the ACE questionnaire and find out who's vulnerable. And if we find out who's vulnerable, maybe we can figure out what their resilience is and teach resilience to do prevention and early intervention. The ACE questionnaire sat on somebody's desk in somebody's lab for years and years and years, and is now being pulled off the shelves in the past years to try to look to see who's vulnerable and how we can do prevention and how we can do early intervention and figure out, we know and can do some predictability on who's vulnerable. We also know some of the ways to teach resiliency. So we need to do that. We need to take the science and bring it to the world, right? The effects of stressful life events across the life cycle happen in all times during our life cycles. What we're seeing here, not just in Rhode Island, but across the country, is that our older adult population is really fitting into this category, especially in the pandemic time. And with the fact that we tightened up prescribing benzodiazepines and opiates, especially to the older adult. And sometimes we've done that abruptly. And what happens is, without help, that older adult population has then turned to someplace else. We're seeing a huge increase in alcohol use in our older adults. And with the life cycle being an isolation with the pandemic, and then loss of family and friends, has caused a lot of problems in that area. And then, of course, we know that mental disorders, principally depression and anxiety, have really raised the bar, have always raised the bar, especially depression and anxiety, high mental health disorders where there's a comorbidity or co-occurring disease with addiction.
Sharon, very quickly, while we were on that slide, a great question came in. With the science of addiction, is there any information regarding transgender pregnant people?
As far as vulnerability?
It seems like a general question regarding information regarding transgender pregnant people experiencing substance use disorder.
I don't have that off the tip of my tongue.
Okay, well, I will save it to the side.
Save it, and then I will look it up and then send something off to you guys.
Wonderful.
Okay. So brain functioning under other similar insults and to addiction is long-term effects of substance use, and even long-term untreated depression can reduce the frontal lobe functioning in the brain. So what does the frontal lobe do? The frontal lobe is where there's planning, executive functions, emotional management, and reasoning occurs. All that kind of, higher level planning, sorting things out, the kind of activity that's used when people begin their early recovery and then developing recovery activities. It's hard to pull all of these things together. If any of you have any adolescents or teens or young adults under the age of 24, we know that their frontal lobes are not at their full capacity yet. In fact, For some, it takes up to the age of 24, 25. When I'm in a college class teaching, I don't say that. I say that with caution because every young person that's sitting in front of me is going to not believe me because they think they're so smart. But at the end of the day, that executive functioning is really going to come back over time. It's going to take some time, but it will. If we were talking about alcohol, I'd have another topic around that. But basically, the functioning does come back. But in early recovery, that's a really tough one. Making good decisions, using all of that, it can be very difficult to do in the very early part of recovery. In addition, if we add head injuries to this, that can produce a similar effect on the frontal lobe. And if we have depression untreated with substance use taking place, as well as a head injury, we've got a lot of stuff. And if it's an alcohol patient, we have other kind of brain impacts. So that frontal lobe is not working to its fullest capacity, and making good decision is not an easy thing to do. Unfortunate thing about addiction and the unfortunate thing about where it sits in the brain is it sits right in the primal part of the brain called the reward center. Early man used that reward center to keep him alive. He would eat something, he'd go hunt, he'd eat it. It would give him a positive reinforcement in his brain to do it again. And that is called survival. Do it again. That felt good. Do it again because it felt good. And so that reward center is really important in our hemostasis of our lives as human beings. But we use natural rewards to stimulate that reward center: food, sex, excitement, comfort. You know, my grandson Gavin, he's 4.5, and I picked him up this morning to take him to daycare because mom needed some help. And when I walk in the room, he runs and he hugs me. My reward center gets sparked by that excitement, by seeing my grandson and him giving me a big hug. The problem is when somebody's been using over and over again a very strong substance, any of them, alcohol, tobacco, methamphetamine, cocaine, you know, all of those things, when it keeps zapping that reward center and it hits it hard and it hits it a lot, the brain is working really hard to take that off, to take it off, to take it off, get rid of that, gets too much on, take it off. And it has neurological changes around that. The other thing is that because this substance is stimulating my reward center, at the end of the day, if I don't use it, I'm going to lose it. And that reward center will not be stimulated when I first get into recovery by the things that would normally do that, like food, sex, excitement. This picture of chocolate, that just kind of like you spark. If you're a real chocolate person, you might just get a little zap on your reward center, but it didn't hit you like something like a substance would. And at the end of the day, this is a real big problem in early recovery, because I'll give you an example. We've got a woman who's been using cocaine, and she's going to Women's Day treatment because she's in reunification and she needs to go to treatment. It's mandated, and she's there, and her mother is watching the 2-year-old, and DCYF is involved, and she's been in 2 weeks in daycare, women's daycare, and is doing very well. Or her urine screens are without any substances except what we prescribe. So she's doing great. She's participating and going to all her groups. They have a meeting with the DCYF worker. Her mom brings the 2-year-old, and her and a clinician are sitting in the room, and they all meet. The baby, the 2-year-old, walks in and goes up to the mom and hugs her leg. And she has hardly a response. She's kind of blank. You're saying, well, what's the matter with you? Don't you feel like all excited? And she's thinking, oh my God, I don't feel a thing. Why am I feeling like I should feel? I must be a bad mother. So if the clinician doesn't understand or explain to the mom that this is going to be a normal response, it's going to get better. But right now it's going to feel weird. And don't beat yourself up with it. So we've got a woman or a man, right, in early recovery with no frontal lobe working and a reward center that won't be rewarded in early recovery. And right now, before I send that woman home for the day, I'm calling one of my, recovery specialists to check in, because she's at such high risk, or he at such high risk for recurring symptoms that evening when I go home, because nothing went right today. And those are really important things to understand. And if the people that we serve don't understand it, then we need to educate them, but first we need to know it too. So understanding how that brain is working, and it will repair. It will repair and things will get better, but it's going to take some time, and early recovery is going to be difficult. So the bottom line from a scientific point of view is just say no is unrealistic. And we know that. We know just say no doesn't work. But on the other hand, out of our mouths is, well, why didn't they just stop? Can't you see all the bad things that are happening to you? That doesn't make any sense. Those are both the same sentences. So just say no is unrealistic for a lot of reasons. Treatment may need to include medications to help the brain, to stabilize, to get some equilibrium, the genetic neurochemical problems, or help the brain to just compensate for that substance that's no longer there, to kind of replacement and to put it there so it stabilizes those neuroreceptors and brings some semblance of order to how the brain is working. You know, this is not a neurobiology class or a whole medication class, but to know that for opiates, there are 3 neuroreceptors in the brain that are affected for opiates. And the one that causes the most problems is the mu. The opiates that go to the mu receptor. That's where most of the issues come with dependency. But for instance, in alcohol, there are 15 different neuroreceptors that have to change for a person to be able to function with alcohol on board and still function. That's called tolerance, right? 15 different neuroreceptors are going through adaptation so that person can walk and talk with a blood alcohol level that might be quite high. So if you take these things away, things have to stabilize somehow, and it's going to take some while to do that. And for some patients, it may take longer than others, and some may need to be on medications for a very long period of time. So let's talk about medication-assisted treatment. Medication-assisted treatment is a comprehensive treatment medication that is shown to increase retention in treatment. And we know that retention in treatment breeds success, that the longer people stay in treatment, the better they do. It decreases illicit opioid use, which is good because right now using illicit substances, opiates, are pretty dangerous. In fact, the newest information that we're getting out is that fentanyl's in everything, including the counterfeit pills that are being on the street, Percodens, Vicodins, you know, just a small amount of fentanyl in those counterfeit pills can really cause major issues with overdose. And while that's happening, it's happening to people who don't even think they're using an opiate, maybe a cocaine user on occasion, and they go ahead and use in there that fentanyl sitting in there. So this does help decrease illicit opiate use. We know that if we have certain populations, like the person who just overdosed is most likely to overdose. The person who's gotten out of incarceration or residential level of care or a nursing home placement who is opiate dependent and comes out without any medication is likely to overdose. We know that postpartum women, if they come off their methadone, we'll talk a little bit about this in a few, if postpartum women come off their medication like methadone or buprenorphine, we know they're most likely to overdose. So we know who's at risk for those areas. So we need to keep an eye specifically to make sure that we watch and that those populations. But we also know that medication-assisted treatment decreases criminal activity, rearrest, and incarceration. And we don't know this just because of this past decade. We've known this since 1978, 1982. This has been evidence-based treatment for a long, long time. What year are we in, guys? It's almost 2022, and we're talking almost 35 to 40 years of evidence-based treatment that's still having trouble making it to the patient bedside. So why we're not getting this evidence-based to where it needs to be is just been an amazing thing to me. It decreases drug-related HIV infections, Hep C, decreased pregnancy-related complications. We know back in the late 70s, early 80s, we stabilized pregnant women on methadone. We didn't have buprenorphine at the time, and we were able to stabilize them and bring them through that pregnancy and go through their whole gestational period. We'll talk a little bit more about that, about methadone in a few. It reduces cravings and fetal exposure to illicit substances. And, it also decreases the kind of activity that may be involved in people trying to get substances by not paying cash, but doing other kind of things to get their drug of choice. And so whether it be prostitution or all those kind of things that can happen, decreases all of that. And we've known this for a long period of time. There are certain medications for the treatment of opiate use disorder that can be used for everyone. And then there's only certain ones that can be used for pregnant people. So methadone, 50 years of research has based that we can use this during pregnancy. And Suboxone, way back in 2010, the mother study indicated that we can use this during pregnancy. The buprenorphine was a combination one. So we here in the United States had a buprenorphine approved for use in pregnant women, but only with Subutex. So that meant Subutex, which was the pure buprenorphine. The buprenorphine naloxone combination, or Suboxone, has not been recommended for use in pregnant women in the United States by the FDA. Interestingly enough, in Canada, they have been using the combination Suboxone, buprenorphine, naloxone combination for about 15 to 20 years now with no ill effects to the baby or mom. And so you can see that the American Society for Addiction Medicine, which is our top professional group, physician group, has recommended that it's okay to use the combination medication, especially if the physician is looking at a woman who, on a cost-benefit analysis, says, I'm going to send this woman home with a 10-day supply of her buprenorphine, but she lives in a community that can be difficult, and there might be a lot of diversion. So it's safer all around for her to go home with the naloxone buprenorphine combination, because there's less risk of using it intravenously and overdosing with it than it is for the pure Subutex. Here in the state and across the country, we're still very focused on using the Subutex. We see some pockets where they're using the Suboxone, but by and large, I can see the FDA hasn't changed their major rule. It's just a recommendation not to. It doesn't say you can't. Naltrexone extended release is absolutely a no. And certainly naloxone is a reversal overdose, which we will use on anyone if we need to keep them alive, but otherwise it's just used for that overdose purpose. Methadone and Subutex are the main medications that we use for pregnancy in the United States right now.
Are there cases where an individual will have to be on methadone for life, or should everyone be able to be stepped down off of it?
I would say that over the years, the research has shown us that 80% of patients will go back to opiate use if they're taken off their medication in 8 months. 60%, 6 months. It's been pretty much the standard response. So the likelihood of returning to opiate use coming off the medication are pretty strong. There are some patients that will need to be on the medication for the rest of their lives. Just like other patients with chronic disease, once that, I get this question all the time, and from a nursing medical perspective, if somebody's got a chronic disease that could kill them, and I've got them on medication that's keeping them alive, and they're doing well on it, and they're not having any ill effects from it, then, unless the patient themselves is adamant about coming off the medication, which they have the right to do, I would never encourage it unless we had some strong evidence that they would do well with it. And if we did take them off that, then I wouldn't just take them off the medication and say, that's good, you're done. I would be wrapping my arms around them during that tapering period, holding them tight, giving them extra support and resources. So if anything should happen, that they even had the urge to want to use, I can bring them right back up on their dose. Or if they did come off the medication and they had urges to use and were gonna, they don't have to go and use, I can bring them right back in and put them right on treatment again. So we just need to be careful. We have to be respectful for people's wants. I have lots of family members who say, I don't want to take all this medication. I'm on too much medication. I said, well, which one do you want to get rid of? The one that keeps your heart pumping or the one that keeps your blood pressure good? You know what I mean? So from a nursing head and a nursing perspective, it's just my point of view that the research is telling us, be careful, it's dangerous. And we're in a population, we're in a world right now where overdoses are sky high and there's tons of fentanyl. We just need to remember that this is a chronic disease. The medication can be extremely helpful and people may have to be on it a long time. And that's okay. And that's okay. I hope I answered that okay.
I think so.
Okay. So what are the number of people that we have in the state of Rhode Island that are on these medications? Now, if you look at Prevent Overdose RI, you'll go there and you can find these numbers yourself. I didn't put the Vivitrol number here, but it's somewhere around 600 as best I can see. And I didn't change the numbers on the slide because the last time I looked at it was June. And I did go back and look about a week or so ago, and it's pretty much the numbers have not changed much. So right now in the state of Rhode Island, we have approximately on this specific day that the data was put up, there was 6,037 patients who are on methadone in the state of Rhode Island. On that same time, there were 5,460 patients on buprenorphine or buprenorphine naloxone or plain buprenorphine. About 500 patients, 600 patients on long-acting, Vivitrol. So if we look at those numbers, we're talking about 12,000 patients, but that doesn't tell us 12,000 patients that have been on the medication for a while. That tells us there's 12,000 patients that have been on medication. I think the important part is not to push people off their medication or to have them discontinue it prematurely, because that certainly does send up red flags for a potential overdose and other kind of things that can happen. So it would be interesting to find out in our methadone or buprenorphine population, what is the average length of time for stay in treatment? Because retention drives success. So just looking at this number tells us something, but it doesn't tell us everything. So those are the kind of things that over time, it would be really interesting to find out what those really look like. So the benefits from pharmacotherapy for pregnant people, pharmacotherapy is a critical element in the treatment of opiate use disorder, providing stability for the woman and the fetus, including prevention of relapse. Pharmacotherapy helps patients with OUD avoid experiencing withdrawal symptoms. So if people have withdrawal, they're more likely to have urges to go use. It could be overwhelming cravings when the opiate misuse is stopped. And so they just have difficulty with that. We talked about the frontal lobe, we talked about the neuroreceptors, but what about the withdrawal itself? How sick can you be? You know, opiate withdrawal looks like the worst flu that you could possibly have. And it's difficult to handle that. So pharmacotherapy can also help pregnant women stop injecting drugs, the primary route of infection for people who use drugs, and it decreases risky behaviors that are associated with drug acquisition. So we have all of that happening, and we know that all of these things are the same for everyone, not just pregnant women, but everybody gets the benefit when they're getting those medications. So let's just talk a little bit about methadone so we understand it a little bit more. Methadone is a full opioid receptor. Remember I said there are 3 opiate receptors in the brain. This particular medication goes right to the mu, which is the culprit of all the receptors. And it's a full agonist, a full opiate agonist. And that means it fully activates the mu receptor to its full extent. It has been accepted since the late 70s for the treatment of opiate use disorder during pregnancy. And it substantially reduces the fluctuations in maternal serum levels. So if I'm a woman out using opiates and I can get some and I take them and then I have a oversedation and then I didn't get enough quick enough and 4 or 5 hours later, I'm sick, opiate withdrawal, then I get some and I'm opiate sedated, and then 5, 6 hours later, I'm in opiate withdrawal. This up and down in the serum levels causes a major issue, especially during the first and second trimester where we can see really bad outcomes happen with that. When we give anybody methadone every day, and once we've got their serum levels where we want them so that they're not basically what we want to happen with giving you methadone, we don't want you to be in opiate withdrawal. We don't want you to be over-sedated. We don't want you to be using anything else but the medications we prescribe or your primary care prescribes for you. And we want to get rid of your urges. If we've done the first three things and we haven't gotten rid of your urges, then your medication is not the right dose. We need to have all those four things happen. And when that happens, then we've gotten stabilization and we can do maintenance and your serum levels should stay even. The methadone also reduces fluctuations in those levels, so that helps during that period, no episodes of withdrawal. In the last trimester, we may have to increase the dose of methadone for the mom because the baby may be taking some of that medication in, and we know that's the case. Pregnant women in their second and third trimester have increased metabolism, and their serum, their blood volume increases. So even a woman who might be taking a different kind of medication, like a medication for her seizure or medication for this, may need an increase in her medication in the last trimester or even the second trimester because she's eaten up that, metabolizing that medication faster. That's the same with methadone. And so we have to increase that dose. If we don't, mom will be sick and baby will be hurt. So that's what we do, keep a close eye. So no problems increasing the dose of the mom to make sure that she and the baby are comfortable. What would that do postpartum? What does that do to the NAS? Nothing. In fact, we know that increasing the methadone dose in the last trimester makes everybody more stable, but it has no correlation to the amount of opiate withdrawal that the baby's going to have, or the NAS the baby's going to have at birth. In fact, 50 to 75% of babies will have some NAS, and that's more likely in methadone than it is in buprenorphine. But there's 25% of babes that are born that have no NAS at all. We can't account for why that happens, but we know it has happened. We do know that there's more NAS with methadone than it is with buprenorphine, because we'll talk about buprenorphine. It's a partial agonist, not a full. And so there's a little bit difference in its effect. But at the end of the day, a woman who has 120 milligrams of methadone at delivery and a woman has 80, both of those babes might have the same amount of NAS. In fact, the one with the mother that's got the lower dose of methadone at birth the baby might actually have more NAS than the other neonate. So we never not increase that dose in that last trimester because we're worried about the amount of NAS. It's not going to make a difference. The baby's going to have it or they're not. And so this is an important part to understand because we don't want to not increase that dose. In fact, if I've got somebody who's been out in the community and I think the woman's pregnant and she's on opiates and she's seeking medication-assisted treatment, she's the first person I'm getting into treatment. I don't want to wait at all for her to be out there. I want her in and working with me right away. Along with comprehensive prenatal care, this allows the mom to be in care to reduce the risk. So not only is she stabilized now on the medication, but we also can now work on her other healthcare stuff. Because remember, we talked about there's a lot of things that influence that NAS and baby outcomes, the fetus outcomes. It's not just about the medication or illicit drug use, it's all the other stuff that goes with it. And this is our opportunity to get in prenatal care and get them ready and get them into treatment. There's never a time that we talk about a medication that we don't talk about the advantages and the disadvantages. I don't know if you guys watch TV lately. I try not to that much, but every time I do, recently it's all about Medicare advertisements, which they're driving me crazy. But all the time, every day, there's a new medication that's out there that none of us can afford, by the way, but it's the best medication since sliced bread. And then after they tell you all the things that's good about it, they have a running list of all the things that are bad about it. And at the end of the day, who wants to take it? But that's the commercial. So there is not a single medication that doesn't have an advantage and a disadvantage. And that's the same here. The advantages for methadone: it reduces and eliminates cravings for opiate use. That's it. It prevents onsets of withdrawal for 24 hours. If I have you on the right dose, 24 hours. It promotes increased physical and emotional health and has a higher treatment retention than other treatments. What are the disadvantages? Achieving a stable dose could take a couple of days to weeks. That's hard. It's much easier to get stabilized on a partial agonist like buprenorphine. Methadone takes a little while. It's a long-acting medication. It lasts for 20, it has a long half-life. So if I give you 30 milligrams today, tomorrow you still have 15 on board, and then I got to give you a little bit more. But your dosage is going to have to go up to 100. I can't do that overnight. It could take me weeks to stabilize you. That's hard. Back in the day, this was the only medication we had for everybody. Imagine having a chronic disease since the 1970s and having one medication to treat everybody with just one med. That doesn't happen for anything, but it did with this. And finally, in the Data 2000 congressional law, they approved buprenorphine to be the second medication to treat, and that took 2 or 3 years to get onto the shelf. So, I mean, it's amazing to look at the disadvantages, but usually it requires, a daily visit to a federally certified opiate treatment program. You have to be certified by the federal government. You have to be approved by the DEA for the way you store your medication. You have to be approved through the state licensing regs for your state. The regulations are called 42 CFR Part 2. They're this thick. And there's tons of rules and regulations, what I can't do, what you can't do, all these kind of things. We've decreased some of those regulations over the past during the pandemic, like everybody had to come in every day forever till this. And we've decreased some of those, and the federal government is looking to see if they can keep those in place. And it doesn't sound like that we're ready to let them go anyway right now based on, what's happening with the pandemic. But obviously, because it's a full agonist and not a partial agonist, there might be a higher risk for overdose with methadone than buprenorphine, although the diversion rates for methadone are very low right now. And actually the overdose with buprenorphine and methadone are extremely low, especially in the state of Rhode Island. It usually requires daily visits, like I said, to the OTP, has longer, and we're expecting longer NAS duration than buprenorphine because buprenorphine is a partial agonist, and it doesn't block the effects of other opiates. So if you're taking a methadone and you use an opiate, you're going to have that effect. And so that is a disadvantage, which buprenorphine, by the way, doesn't have. So buprenorphine is also a mu opiate receptor, but it's a partial agonist. It has a ceiling effect. I can increase your dose of medication, but at some point in time, I could increase your dose, but you're not going to feel the effects of it anymore. It's as high as I can go. So if I can go up to 16 milligrams is the average dose that most people stabilize with buprenorphine. If I have to go up a little higher, especially maybe if you're a pregnant woman in your last trimester, I have to go up a little higher. I may have to increase your dose. And actually, we're having good effects with that with pregnant women. So their ceiling effect seems to go up in the last trimester. But at some point in time, if I keep going up, you're not going to feel the effects of the meds anymore, has no effect. And yet you're still not maintained and stabilized. You're still having some use of stuff I'm not prescribing. You're still having urges to use. If all that's the case, then this might not be the medication recommended for you. However, we're finding with our years of more experience that most people are able to stabilize on 16 milligrams or lower, and the ceiling effect has not caused a lot of problems. But we do know that buprenorphine is really sticky, and it has that benefit, and we'll talk about that in a minute. It comes in several formulations, so there's plain buprenorphine, Suboxone, there's buprenorphine with naloxone. That was to help prevent diversion, and if you were to crush buprenorphine, which normally gets absorbed in your mouth, either in your cheeks, inside your cheeks, which are buccal, or sublingual under your tongue, it gets absorbed there. Naloxone doesn't get absorbed there, it likes intravenous. So if you crush this and you try to inject it, you won't feel anything. So that was the biggest issue from the federal government and the FDA before it could go onto the shelves for prescribing. It had to be in a combination form. There are new products now that are injectables, that are transdermal, other ways to take that. So there's all different kind of products that have come out since it first hit the shelves. So what are the advantages of buprenorphine? There is a lower risk of overdose with buprenorphine than methadone, but we're not seeing a lot of overdoses on either one of those. We are seeing a lot of diversion on buprenorphine across the country. I'm not sure about the diversion as much here in Rhode Island because we have access to buprenorphine in Rhode Island. But for the states where there's no access to buprenorphine, we're seeing lots of diversion. And that's because people are trying to buy it on the street because they're afraid to use what's on the street. So they prefer to buy a dose of buprenorphine from a friend, take it, prevent withdrawal, but also prevent using stuff that they don't know what's on the street. The government has then decreased some of the restrictions on doctors getting their buprenorphine waiver. They also increased the ability based on the CARA Act to allow nurse practitioners and physician's assistants to get their waiver to prescribe buprenorphine so that we could get more people out there prescribing and less people on the streets trying to purchase it. I've talked to many physicians and nurse practitioners and physician's assistants who bring people into their practices who were using buprenorphine on the street, and they weren't abusing it to the point where they were taking more to get high with it. It's not a medication that causes a lot of that highness that people think they're seeking. They're looking really not to be sick. And so when they would bring them into their practice, they would say, okay, what are you taking on the street? And the guy would say, I'm taking, or the girl would say, I'm taking 8 milligrams every day. And sure enough, the doctors would bring them in and put them on 8 milligrams every day. It was just the right dose for them to be stable and maintained, but legitimately in a physician's practice instead of diverting on the street. So it's an interesting medication as we go through the course. Of course, the nice part of advantages is you don't have to go to a opiate treatment program where you have to follow all these rules. The federal regulations are pretty strong and strict on how many urines you're going to do, all that kind of stuff, how many things you have to, times you have to go to the clinic, how many sessions you need to have, a lot of stuff that puts people in a place where they might not want to stay in treatment because they got so much to do. Usually we have a shorter NAS course when we have patients on buprenorphine, but what we do know is if a woman is on buprenorphine and then becomes pregnant, she should stay on buprenorphine. If a woman is on methadone and then becomes pregnant, she should stay on methadone. We should not be switching after the pregnancy starts. We stay all on one thing. So the NAS course is shorter. It blocks other opiates. So remember I said that buprenorphine is really sticky. So when it sits on that mu receptor, if you try to use another opiate, almost kind of sort of like naloxone or naltrexone, because it's stickier, it's not letting that opiate on. So it blocks that from you using. However, if you were to use naltrexone, that's the boss. It knocks everything off. So methadone's not sticky, buprenorphine's stickier, and naltrexone is stickiest. So it's going to take over that receptor site. So because buprenorphine is sticky, even though it doesn't have a long half-life, you can still take this medication once a day, just like methadone has a long half-life once a day, but it's not sticky. Buprenorphine's super sticky, not a long half-life, but you usually can take it once a day. For some people, like pregnant women and people with pain, they can actually take it, divide the dose and take it twice a day, and it works really much better. So it's up to the patient and the doctor, the prescriber, as to how that's going to work. And of course, like I said, unlike methadone, this comes in longer acting formulations, which are patches and things like that. So what are the disadvantages? We're still looking at the data. We're almost done looking at the data. We're looking to see fetal exposure data looks as good as methadone did, if not better. And we have 40 years of methadone data as far as long-term effects on fetal exposure, although we're still working on both to constantly measure what is happening. And then it demonstrated clinical withdrawal symptoms. We can see those. The withdrawal symptoms may be present, and we may not be able to take care of all of them because this has that ceiling effect. And then sometimes we believe that because it's not such a long-acting med and People might feel that it's easier to get off this medication, which in fact, we found that it's not, but they seem sometimes there's been lower retention in treatment other than methadone, because once patients get on methadone, it's a long-acting medication and that might be difficult for them to taper off. And we think that people might walk off of buprenorphine treatment easier. What we're finding though, that this disadvantage may be going off that with more data and research. We're finding that people are being retained in buprenorphine as well.
Very quickly, Sharon, a couple questions did pop in. So the first question that popped in is, why are some people prescribed methadone and others are prescribed Suboxone?
Well, that's a good question. There's a couple of reasons for that. Methadone programs have a ton of wraparound services. They also, at a certain point when we first started buprenorphine, were reimbursable by Medicaid. They also were funded methadone slots. So for those patients or people who didn't have insurance or insurance that would pay and this and that, could have been a cost impact on it. The second thing is that methadone's been around since the 1970s. Buprenorphine didn't start, it got approved in 2000. It didn't hit the shelf until 2003. So we have more experience with methadone treatment and people have been stabilized that for a long period of time. So it's cost. It's also wraparound services that are available. Some people really need all those services. They're not an inconvenience. It's what they want. You get a case manager, you get counseling, you get other kind of things. The methadone programs here in Rhode Island have health homes wraparound services. So if you're going to a private care physician, in a way physician, that might be fine for you, but I'm a person that needs more of these wraparound services. And also, we also know that some patients can't stabilize on buprenorphine. They really need a longer acting, a full agonist. So I can't get control of your withdrawal. That means you're still using, this is not the right medication for you. So there's a lot of different reasons. And then the last and the best reason is patient preference.
Wonderful. Two other questions. The other one is, should Suboxone be tried first before methadone or even vice versa?
No, I think they should be, we should talk about them equally. My personal opinion, and from a medical perspective, although I'm not a physician, a nurse, is that I've got you sitting in front of me and you've got a chronic disease. And in my toolbox, I've got 2 tools. Now, if you had diabetes, I would have 50 tools, but you've got an opiate use disorder. I only have 2. Actually, I have 3, right? I can use naltrexone, Withdrawal. I got 3 tools in my toolbox. I'm looking at your chronicity. I'm looking at the psychosocial behavioral kind of components that I think you need. Coming to my office once a month for buprenorphine and going home with nothing is probably not my recommendation. So I'm going to use my assessment skills as a physician. And then as a patient, you have the right to decide. So I don't think one should be priced over the other. I think the physician and the patient should look at what's happening and together make a good decision about what's the best medication for me. That's how we practice medicine.
Another question was, if people who are actively using fentanyl, would they be better on methadone or Suboxone?
That's a really good question. We're still trying to figure that one out. They probably can do well on Suboxone, at either one, I guess. But fentanyl is such a strong medication. And even for patients that are on methadone, which is a full agonist, and of course, fentanyl is a full agonist, right? They're both a full agonist. So I can stabilize you on the buprenorphine if you're using fentanyl, but it's gonna, I think it might be harder, and it depends on the patient as well. We've had doctors talk about patients that are stable on methadone, then have a reoccurrence with fentanyl, and then trying to restabilize on their methadone has been hard because of the fentanyl is so strong. So if it's a strong fentanyl user, having a full agonist might be more beneficial, but I wouldn't rule out that they couldn't stabilize on the buprenorphine either. You know, taking medication for any other thing is a trial and error. This is working, this one's not. For this population of people, they have to go to one place. If you're in another part of the country, there is no such thing as a methadone program. You have buprenorphine's it, and that's if you can find it. Here, at least in Rhode Island, our patients can have choice, which is huge.
Couple more, and then I promise I'll give the reins right back to you.
No problem.
So before I ask this one about staffing shortages, the other one that came in regards to MAT is that a scenario popped up is that this person has a few clients that are pregnant that are not wanting to be on MAT of any kind because they feel that the baby would still be negatively affected by substances and may go through a withdrawal. Is there any accuracy to this feeling?
Not as far as I can see. All the research has told us that are they currently using anything? If they are, then the answer is not at all. They need to get on this medication. If they're in recovery and worried about reoccurring symptoms during their pregnancy, that's a different story. So if these women are actively using opiates, then that's where their baby is at risk. Yeah, the medication, it shows so much more, such more stabilization and safer, and it's got 40 years of history to tell us that. There are some really good handouts on the SAMHSA website. I think I've got them at the end of the slides to show you. That may be something to help educate the moms.
Wonderful. Thank you, Sharon. Another question that just popped up too is that if a pregnant mother who may need MAT doesn't have insurance coverage, does the patient still have a preference, or does the doctor have to prescribe the appropriate med based on that insurance accessibility?
Well, that's the same thing for any disease and any patient who doesn't have insurance or does. I mean, I'm an older adult with Medicare. I can't get all my meds either. And that's how the doctor doesn't prescribe that one because I can't afford it. So that's pretty much, I think insurance drives a lot of stuff, but an uninsured mother probably has more options right now than an insured mother.
Final question is that, this person shared that, I think this was tied into your point about enhancing our capacity to prescribe, that this person's hearing about staff shortages at methadone programs. Is this primarily, this person must be operating in South County. So is this primarily a South County issue, or is this less of an issue than being reported by clients?
No, this is a national issue. And this is a local issue in every single, I can't talk to any clinical program where there's not openings up the kazoo. It's crazy. I've never seen a workforce so depleted. And what I'm worried about is not just the workforce, but the quality of the workforce as well. A lot of our older adults have retired or not working in the field. And then even when I think of some of our older experienced clinicians, do they know the new stuff? Just because you've been working in something for 50 years doesn't mean that you know all the new evidence-based practices. Every day I learn something new that's coming out in science around these issues. So just experience without knowledge doesn't make the workforce better. But if we've got a brand new workforce that's depleted, I'm not sure who's the mentoring. So we've got a national crisis, and it's just not in a methadone program.
I can echo that, Sharon. So very true. And I think that was it. So I will hand it right back over to you.
Okay, all righty. So I'm just looking at the time. How much time do I have?
You have, let's see, you have 35 minutes.
Okay. So when we're looking at medically supervised withdrawal, and a lot of the women will come and say, they're not on any MAT, they're not on buprenorphine, they're not on methadone, and they come in and they're using opiates, and they say, I need a detox. Bringing a woman into and we call it medically supervised withdrawal because it doesn't sound so horrible, but bringing a woman who's been using actively on the street, who's pregnant, I don't know if there's any detox in the state of Rhode Island that would take that woman off her opiates and not put her onto medication-assisted treatment. It is so not recommended. It has not been recommended for at least 40 years. So they're at high risk for relapse. They're at low risk for no completion rates. They never finish if you take them off completely. Pharmacotherapy is recommended standard of care and the best practice for pregnant women with OUD. End of decision. That's it. So if we need to find out what's that education, how do I educate the mom? How do I give her this information so she can make her decision? But let her make the decision from knowledge, from education, from real information, not just how I feel or what I think, but real knowledge. Remaining on pharmacotherapy helps pregnant women with OUD avoid to return to substance use, which is the potential for overdose or death. Pregnant patients should be advised that withdrawal during pregnancy increases the risk of relapse without fetal or maternal benefit. No one benefits from that. And of the benefits that I've seen from maintaining during the pregnancy, and then after, we'll talk about after, and how dangerous that is at that point in time. So this is an educational opportunity. Who are the people that, want to convince people to get off medication? This pregnancy window of opportunity, this is our time to really look at, postpartum women, men, the families are so vulnerable, right? Increased stress associated with caring for a newborn, the sleep deprivation that happens, never mind that there's a substance use disorder. This is just without that. Limited social supports and resources may not be available. How many family members are around? Do you have an extended family that lives with you and are they on board with you? Increased financial demands with the baby. How much does it cost to have that? Pain and physical recovery from delivery itself, and the decrease in the amount of medication that people want to give somebody who's got an opiate use disorder. Do you have to be in pain? No, no one should be in pain. And the physiological transition from pregnant to a non-pregnant state, take away the substance use disorder, there's all kinds of increased risk of relapse and treatment discontinuation. And this is called the postpartum fourth trimester. So this period from 7 months to 12 months, completely after that fourth trimester, that whole first year after delivery is an opportunity for so many things, but an opportunity also recognizing the vulnerability of all the things that are happening with this woman and the support that she needs in this. And I know that we're going to hear from our parent support network about all of this when they're on in a little bit. And they are essential to this postpartum period to give mom support and all of that. And who are the people, what are the pressures for discontinuing? If I've got you right through that pregnancy and you've come out and you've done well and you've taken your medication as prescribed, you did your prenatal care, there's nothing else going on except that you're taking your medication for your chronic disease, then you're going to go home. And that's a great thing. And that doesn't happen across the country. Women are in hiding. They don't want to tell anybody. It's not the same. We do a really good job in Rhode Island, but we could get better with universal precautions and collaboration for sure. So why would someone want to come off the medication if they've done so well? Well, pressures from family and friends. Yeah, is pressures from treatment programs or the legal system. Absolutely. The cost of the medication. Do I still have the same coverage when I'm not pregnant anymore? Time needed and other responsibilities. If it's a methadone program, do I have to go more often and I can't make it there? Fear, prejudice, and discrimination, and wanting to use again, just plain urges that are hard to control. Postpartum, these are all the things that cause women to discontinue in that first year. And it's a really dangerous time for that to happen. So educating not just the mom, not just the family, but everybody is so important to not push for people to get off their medication when they've done so well on it, right? This is the clinical guidelines for treating pregnant women and parenting women with opiate use disorders in their infants that came out of SAMHSA. It's been out for a couple of years, and it's an unbelievable resource for everyone. But if you look at this next page, you can see that healthy pregnant, healthy baby, healthy pregnancy, healthy baby. There are multiple 1, 2, 3, 4 patient education sheets and staff education sheets that you can print out from the SAMHSA site. And one discusses opiate use disorder in pregnancy. One is treating opiate use disorder during pregnancy. One is treating babies who are exposed to opiates before birth and good care for you and your baby while receiving opiate use disorder treatment. What a great handout and patient education handout for those moms who we want to educate about opiates and their baby so they can make good decisions. This would be a great handout for that. These are on their website. It's on the bottom. You can pull this up and print them out. The handbook, the guideline, usually is free, and you can get it for free, and they'll send it to you for free, except they're usually out of them, but you can download it and you can actually print it out. These things are easy to download, and they're one sheet, and they're great resources for staff as well as families. 2016 Comprehensive Addiction and Recovery Act went into play, and here in Rhode Island we have actually put it into practice, and that's not the case everywhere, even though it's a federal law. Further clarified the population of infants requiring a plan of safe care, not just babies born with moms who have opiate use disorders, but born with and identified as being affected by substance abuse or withdrawal symptoms resulting from prenatal drug exposure or a fetal alcohol spectrum disorder, specifically removing the word illegal. So this law came into effect. It required a plan of safe care to include needs for both the infant and the family and the caregiver. The development of a plan of safe care for the infant born and identified as being affected by substance abuse or withdrawal symptoms, or FASD, to ensure safety and well-being of each infant following release from the care of healthcare providers, including through 1, addressing the health and substance use disorder treatment needs of the infant and affected family caregivers. So this act has been in effect, and I know that our birthing hospitals have working closely with the Department of Health and our other providers to put it into play. So at the end of the day, the good work that we're doing here in Rhode Island needs to be enhanced even more. And I think we're going to do that through better collaboration with critical partners in our community. Who are those? Child welfare working together, criminal justice, employment programs, mental health, welfare, early intervention, child development, legal aid, all of the things that happen, but we just need to talk to each other better and collaborate better, talking about home visits, faith-based organization, housing. We can even give mom all the medication she needs and this, but if she doesn't have all these other supports, the family needs all of those things. In order to do all the stuff that we just talked about, we have to do screening. And that we can't do just in a behavioral health organization, or just, which by the way would be mental health and substance use treatment, right? Or just in a prenatal clinic, or just in here. Screening needs to happen pretty much everywhere a person shows up, at least if they're going to be doing the continued care. We have screenings in the emergency rooms, but those are for acute stuff. So we need to have these added pieces in. And remember, to teach screenings doesn't mean that you have a person that you just say, okay, ask the patient this question, ask the patient these questions, because we need to know that the person who is doing the screening is doing it in a way that that person will answer the questions honestly. So I remember, and this is a good story, but I remember taking a family member at 3 o'clock in the morning, pre-pandemic, to an emergency room that will remain unnamed. 3 o'clock in the morning, and he's having trouble, shortness of breath and having trouble breathing, but the nurse is insistent that she asks these questions, and then she apologizes for asking them. And the question is, which is mandatory in the emergency room, are you suicidal? That's the question she wants to ask. But before she asks it, she apologizes 5 times that she's going to ask this question. It's really stupid. I'm sorry I have to ask this question of you. She apologized so many times to tell the person that the question was stupid that when she finally asked the question, he never would have answered it correctly if he was, because of the way she presented it. So screening is one thing, having a tool is one thing, but drilling down to find how your staff going to ask the questions, and they do it in a way that is not confrontational or is trauma informed and allows the person on the other side to actually answer it honestly, is a pretty big deal. We screen for almost every chronic disease that we know. We're screening for cholesterol and triglycerides in our kids in the pediatrician's office. We're screening for this, for that. But these kind of screenings, when it comes to substance use and mental health and suicide and those kind of things, we're not screening all for that kind of stuff. You know, it's an interesting thing is that we've got in the pregnant women right now, the highest diseases, the highest things that are associated with death in pregnant women that are not related to their pregnancy. Death related to pregnancy would be she went to deliver her baby and had a hemorrhage and died during because of a pregnancy related issue. The three top pregnancy associated deaths not related to the pregnancy itself, but during pregnancy is homicide, suicide, and overdose. Those are the three top ones. And the one thing that goes across all of those, the one thing that's a common theme across all of those is intimate partner violence, which is not screened for much at all. So these are all kinds of information and things that we're looking at to see how can we screen universally, not just one person or that person or that one. Oh, that person looks like they need that screening. Oh, that person's okay. We miss that if we do that way. So screening should be universal and comprehensive, past, present, when we're talking about opiates specifically or substance use, alcohol, tobacco, high-risk behaviors, exposure to interpersonal violence is there, but it's not looked at a lot. And the comorbid behavioral health disorders, depression, anxiety, all those, we can't screen for everything, but we've got to decide what our population looks like, what can we screen for effectively, and not try to do all things, all people, all the time, but collaborate with our partners because they might have information. So let's start duplicating what we're doing and share information. We can do that if we do it right. Why should we do universal screening? Early identification can minimize potential harms to mothers and pregnancies and maximize motivation for change. Selective screening is based on risk factors such as poor adherence to prenatal care or their prior adverse pregnancy outcomes can lead to missed cases and may add to stereotyping and stigma. So if you select who you do the screening for, that's not universal and it should not be done that way. Universal is recommended by our OBGYN group and has been since 2017. So that's kind of sort of where we need to go. But what are the barriers to screening? Reimbursement concerns. It's taken too long. I don't get reimbursed for that. Time constraints, limited knowledge of referral options. Now, I'm going to stop screening for that because I don't have any place to send anybody anyway. And personal and professional discomfort with addressing, like that nurse who keep apologizing for asking the suicide question. And then stigmas and biases always come into play, our own attitudes. And then we need to train people more on screening, brief intervention, and referral to treatment. It's an evidence-based practice, expert, and teaching that to the people who are working for us is important. We need to drill down in our own organization to feel where's our staff feeling with this? What's their education? What are their struggles with their own stuff? And so many people bring their own experiences to the table. And sometimes those experiences are helpful and sometimes those experiences can be harmful. So we need to think about as we go. What are the benefits of working together? Increase early intervention opportunities across multiple service systems, cross-training each other, screening, using different kind of, using the same kind of screening tools, those kind of things, leveraging expertise and resources in a collaborative multidisciplinary team. Each program is able to increase the expertise in different service delivery systems. When we come together as a group and we have different kind of hats on, it just increases the experience and opportunities to get creative about what we can do. Increase the ability to meet concurrent and multiple needs through flexibility and the different breadths of resources that may be available. And basically, we know the benefit improves outcomes for families, elimination of conflicting requirements, maximizing of resources, and more client-driven and less fragmented services that we might do. Bring in the families, ask them what they need, and then cost-effective. Reduction in duplicative services, maximizing funding through economics of scale, and leveraging resources to expand. The more we work together, the more we collaborate and talk, the more we can share, the more benefits it brings to our families and satisfaction to ourselves as well. So I'm having a feeling that I'm probably early in my finishing, but that's okay, because then we can have some time. Do we have time for a couple more questions?
Absolutely. And there's actually a couple that popped in. So
Right,
you are ahead of schedule, Sharon. That was magical.
I know.
So the first question that I see in our Q&A box is, it was a follow-up question for clarification. Is there a difference between a pregnant woman that experiences lapses in her recovery and uses 1 to 2 times during the first 6 months of her pregnancy, and a woman that uses daily, or for both scenarios, would MAT be the best and most recommended option?
You know, if it's opiates that we're talking about, the answer is MAT would be the best option, because there's very few women who are going to just use once in a while during their pregnancy for opiates. I really see it. So I think, you know, if somebody has got a mild, let's look at the DSM-5. It's mild, moderate, and severe for all opiate use disorder, or any substance use disorder, right? If I've got a mild opiate use disorder as determined by the DSM criteria, I might not need an opiate medication replacement like MAT if I wasn't pregnant. But the safest bet, even for a mild opiate use disorder woman who's pregnant, who might occasionally be using, I think MAT would be the recommendation. If that was an alcohol patient, one drink during the pregnancy is 1 drink too many. There is no good amount of alcohol during a pregnancy time when I'm out ever.
Wonderful.
Did I miss a part of that question?
No, I don't think that you did. I think you answered that.
Okay.
Okay, the next one in our Q&A box is, it's not specific to an opioid situation, but there's a client who is concerned with the effects of, if we're thinking of substance exposure, her bipolar medication on her pregnancy. And the suggestion came to continue her meds, as there isn't enough evidence that the baby will be negatively affected. And this person just wants to confirm, like, is this the correct approach with those medications?
Well, you know, I don't know what the name of the medication is, so it's kind of hard to answer that question, because there's all different kind of medications that have different things. There are certain medications for pregnant women that we know they cannot take. And those medications we know. Then there's this group of medications that we call a category C. That would be the naloxone that we talked about. It's a category C medication for pregnant women. And the reason why it's a category C is because we don't have enough information. And it doesn't mean that it's going to cause any bad harm, but we don't have any evidence that it will cause harm, and we don't have any evidence that it won't completely. So it's kind of sitting on the line, and that's probably the medication that she's got right now. It's probably a category C. And if I were to take her off that medication, what bad things could happen from that is probably worse than a category C med. So as a physician, I'm recommending you stay on it.
Excellent. Thank you. Another question just popped in, is that this person they shared that they have 27 years of taking care of infants withdrawing from opiates, and shared just the practice that the OBGYN is typically not in contact with the doctor in the clinic. The exchange of the medications, urine tox, et cetera, will be pertinent in the care. Just they're curious, why does this process happen this way?
I think that was part of the reason why we're doing this webinar today, is to try to get the partners that are taking care of the patients to talk to each other. I mean, OBGYN should be talking. They should, and when mom is in the hospital and she's on MAT and she's on a methadone dose and she wants to breastfeed, she should. It's recommended and has been for 30 years. But the dose that she was taking during her trimester before the baby may have been increased because it needed to be. And right now, evaluating whether her dose is the proper dose, she may not need the same medication, and she might. And maybe the OBGYN doesn't know how to evaluate that. That's when, why would you not talk to the prescriber of the medication? If the mom was a diabetic and her insulin needed to be adjusted in her last trimester, and then postpartum her insulin needed to be adjusted again, who would you talk to? You talk to the endocrinologist. That's how it should happen, in my opinion.
Thank you, Sharon. And that is actually our last question that I have in here. So I think at this point, I get to turn it back over to, well, first, before I forget, I know that we had a question earlier that Sharon, I've saved for you for following up in regards to mothers or women, females, the assigned female at birth using marijuana. So I will turn that question back over to you.
Yeah. The newest research come out, and I'm trying to rack my brain to think of exactly what we're talking about. But Margo, I see Margo popped up on the screen. Thank you. Do you remember that article you sent me?
No.
Okay, so I'll try to remember it. So some of the newest research is coming out, and it's still preliminary, but and there's a huge increase in the amount of marijuana use in pregnant women. A lot of people are thinking that, you know, because marijuana is more out there and but the cannabis is really proving in the early research articles to begin to show that there are learning disabilities for the babes in short course that they're beginning to see within early development. And that's showing up pretty obvious in the early research. We don't have a lot of it, but it is not a recommendation anywhere right now that it's okay for a mom to have an occasional cannabis. Just like I've heard lots of people not reinforce it's not okay to have an occasional, you can have an occasional glass of wine while you're pregnant. The answer is absolutely not. But we're not sending that message all the time. We need to start sending that message. And the research on the alcohol is so clear. The effects of alcohol on the fetus is just unbelievably clear. It's probably the most research we have on the impact of a substance on the baby. And yet it's not something that's out there as strong as it should be. So I've been reinforcing the alcohol piece. Cannabis is starting to show up very similar, although the research is not all in yet.
So with that last, just when you were just addressing that last question, a couple other things just popped in.
Yep.
So kind of related right to, there's two comments that kind of came in with the question built in that I think tie right to what you're talking about. The first is, you know, the mothers that don't want to be on MAT, but occasionally use, if they come to the hospital when the urine is tested and it's positive for opiates, it seems that these mothers are not realizing that that typically is a call to DCYF. So the comment is please encouraging MAT treatments for these pregnant people, and that the clinics, when they are on MAT, do not to try to prepare the mother for what their child will go through for withdrawal. Just really, this is just kind of a call to enhance what you're saying, that clinics need to educate their patients.
Yeah, they do. So, you know, mom, you know, you can't make mom not use. And you don't want to take, if she's on MAT in a clinic and she's having an occasional use issue, the MAT provider should not be stopping her treatment. You have to continue the treatment. But she needs to be educated that if her urine screen is positive for something else that's not prescribed, there's going to be consequences to that. And she should not be surprised when she walks in the door that's the case. That should be quite clear and evident to her. And if she's surprised, then we should be educating more around that. And this is where that collaboration comes in. If we've got this woman in the right treatment, but we're doing kind of a harm reduction approach. It's kind of like, in today's world, when somebody comes in to get medication-assisted treatment for their opiate use disorder, we shouldn't have this high bar that stops them. We should have a really low bar. Come on in. It should be medication first, not, you can come and get this medication, but you got to do this. Well, I'm not ready for all of that, but I can't have the med. No, you can't have the med. You got to do this. The bar should be low. It should be a medication first approach. The bar on discharge from MAT should be so high. It should be when people have symptoms of their chronic disease, we shouldn't be telling them goodbye. We should be saying, come on, let's think of some more stuff. So, but these women need to be educated so that they know that if they're using and it's happening, even though they're on MAT, they still could be, looking at some consequences. I agree.
The next question that came in is in response, I believe, to your comments in regards to highlighting that there's no, that one glass of wine while you're pregnant it should never be part of the recommendation ever. So the scenarios coming up is that there's still some other providers that are working with pregnant people who are saying that is okay. So is there a recommendation for how you would handle that type of scenario when there are two different sources of information coming into play?
Yeah, I'd have them go to the www.fasd. It's fetal alcohol syndrome, FASD, and you'll have a full education around those issues. And so this is, once again, where education to our clinical staff, our medical staff is imperative. We have these huge numbers of addiction issues. And even though we're getting better at educating medical professionals and clinical staff, we're still not doing that as good as we should to make sure that they have all the information. As far as the fetal alcohol syndrome national site goes, no drink anytime during the pregnancy is appropriate. So if you're even thinking of getting pregnant, but you're not yet, you should not be having the drink. The impact of alcohol on the fetus is unbelievable. And we don't always see it at birth. This is where we begin to see it. I don't know. We've got an awful lot of stuff happening, with people drinking during their pregnancy. So.
Another question, and I know obviously, Sharon, a lot of the things that we're talking about are very Rhode Island specific. This person, this attendee was asking if we know anything about how does it work in New Jersey for the women to get the methadone after birth, or if we have like maybe even a resource in regards to that.
Yeah, every state has a state methadone authority. So if you go to the state licensing, whoever that is, for us, it's Buddha, right? And if you go to the New Jersey Methadone State Authority, you should pull that up. New England and the Eastern Seaboard is pretty good as it comes to the ability to get methadone and medication for pregnant women. It's the more rural parts of the country, middle of the country, who are struggling, and even the Northwest. But right down from New York to New Jersey, there should be plenty of treatment available, and they should be on top of their game for that.
Wonderful. And this is actually our last question before we turn it back over to Margo. So in regards to your slide on language matters, you mentioned
Yes.
we shouldn't use words like addict, which this person would not use on their own. But what are your thoughts about individuals who consider addict as part of their identity?
Yeah, that's it. I'm so glad they brought that question up, because we've been working on it. It's funny because I think of this as a professional looking at that, but the person who sees themselves and has seen themselves as an addict, if they want to refer to themselves as that, that's their prerogative. I'm not going to say that to them.
Wonderful. Thank you so much, Sharon. And at this point, I get to hand it back over to our colleague, Margo.
Thank you.
So thank you, everyone. Sharon, fantastic as always. I learned so much from you. Just like Katie said earlier, every time it's more and more. And thank you for all the great questions as well. So Judge Leah Stolsatz is an associate justice in the Rhode Island Family Court. She graduated from Smith College, one of my alma maters, in 1990, and Howard University's Black College Exchange Program. As a Teach for America Corps member, she taught junior high social studies in the Washington Heights section of New York City. While getting her law degree from CUNY School of Law, she worked for Catholic Charities as a social worker in a program serving incarcerated mothers held at Rikers Island and Bedford Hills Correctional Facility. Following law school, she was employed by the New Hampshire Public Defender as a trial attorney. She moved to Rhode Island in 1998 and joined Rhode Island Legal Services, where she represented clients in both the Domestic Violence Unit and the DCYF unit. Judge Leah was appointed to the bench by Governor Gina Raimondo in 2016 and has been assigned to the juvenile calendar, the DCYF calendar, and Safe and Secure Baby Court. Magistrate Jean L. Shepard received her BA from Middlebury College and her JD from Suffolk University. She was appointed to the Rhode Island Family Court Judiciary in 1999 and served as the inaugural Juvenile Drug Court Judicial Officer until 2022. Which hasn't even happened yet. Since 2002, Magistrate Shepard has presided over the domestic abuse calendar and the family treatment drug court program, both of which she developed with various stakeholders and grant funders. She presents and teaches on topics such as domestic relations, family law mediation, domestic violence, drug court treatment programs, and child protective matters. In 2007, Magistrate Shepard was honored with the annual Sojourner House Justice and Advocacy Award for her work and advocacy with the domestic violence community. I welcome you both and thank you for being such friends of the program.
Good afternoon, everyone. I'm Magistrate Shepard, and as you've heard, I've been on the Family Treatment Drug Court since the beginning. And it took us probably about a year of planning and effort to put the program together. And when Margo said stakeholders, we meant everybody, federal and state. We got some money from our federal delegation initially. We received a grant from OJJDP. We had every state department that touches children involved intimately. And most importantly, we had Women and Infants Hospital, because originally Family Treatment Drug Court started out in conjunction with the Vulnerable Infants Program. Anyone who remembers that one, Dr. Lester. And it was a really good program. It was a quick program. Cases were flagged at the hospital and then flagged by DCYF. And at one point, we even did arraignments in Family Treatment Drug Court. The calendar has changed over the years, which is a good thing. And it's really works hand in hand with Safe and Secure Baby Court. And the system now is a great system. It's a unified intake that frankly can be done pre-DCYF petition. For example, a parent could self-refer, a social worker from DCYF could self-refer, even a doctor's office, OBGYN, social workers. Once we get that information, the court has no jurisdiction at all to do anything except keep the information until DCYF files a petition. So that is the event, if you will, that confers jurisdiction on the Rhode Island Family Court, a DCYF petition alleging neglect or dependency. For drug court, it's neglect. Substance exposed baby born to substance using parents, that's a neglect. Safe and Secure can go in as a dependency, family in need of services. And Judge Stolzatz will address the unique aspects of that program. So right now, cases are arraigned by the DCYF judges, and we have 3, I believe. And attorneys are appointed at arraignment for the parents. It's very important that parents get the benefit of legal counsel, because to come into drug court, a parent or parents must admit to neglect. And as we all know, that has ramifications for future. For example, if a parent or parents do not successfully complete the drug court program, cases are referred back to the DCYF calendar, and that finding of neglect stands. So with that, I hope Judge Leah has, because I think it'd be perfect segue for Judge Leah to talk about how cases specifically get to drug court and or safe and secure, which are two different tracks, but almost the same exact staff. No audio yet. All right. The Universal Intake Department is basically right now, I think, 4 social workers. All 4 of them have the capability. They're mostly LICSWs, and they take a pretty significant history and do a battery of substance abuse tests and family functioning assessments and that sort of thing, ACEs and all the domains that we need to know about. And then the social workers, these are family court employees, mind you, they're located on the 3rd floor, which is literally behind me. I'm on the 3rd floor also. The social workers make a referral, which track would be most appropriate. And actually there are 3 choices. Regular DCYF calendar, the person or persons don't qualify or they're not interested. Safe and secure baby court, which is really, I think, meant for newborns and new mothers and new parents who just need the help of the state. And then family treatment drug court, we take I will say the more difficult population in the sense of serious drug issues, not just marijuana, but usually it's a multitude, a poly use of substances, coupled with a lot of not healthy living, poor relationships, domestic violence, homelessness, mental health issues. Trauma is huge in drug court. I think pretty much every single person in drug court has experienced some sort of trauma. Some have experienced significant trauma and continue to do so. Once the assessment is made, by the way, those assessments are confidential, protective orders issued. The judges don't see those assessments. All we get is a paragraph from the social worker saying the person qualifies or they don't qualify, and then where the child is placed. In drug court, for the most part, at the ex parte and arraignment level, the children are not placed with parents. I think in safe and secure baby court, more likely that a newborn would be placed with a parent or parents because bonding is so important. We have no disqualifications per se, except on a couple of points. If the mental health issues are so significant that we think a parent or parents are just not going to be able to participate fully, that may impact our decision-making whether to accept a parent into drug court, because drug court's hard. You have to really, really be present and mindful and want to change in order to succeed in drug court. The other disqualifier, when I say disqualifier, I mean that loosely, is defendants who, and I say that, who have pending violent charges, for example, child abuse or neglect on the criminal side, that may not be acceptable for drug court, or domestic violence on usually a father, could be a mother as well. I have had people couples in drug court with domestic violence offenses, and they have worked through those issues. I'm a little leery on that. We hear those cases separately, particularly where there's a no contact order. I have to tell you, drug court is on WebEx platform, Tuesday, Wednesday, and Thursday afternoons from 2 to 4. The only time I really see people live in person now is at 12 o'clock Tuesday, Wednesday, and Thursday for the event we call orientation. That's the event where a participant, in conjunction with their attorney and after legal advice, decides to admit to neglect, agree to participate in the drug court program, give up all their trial rights, and agree to allow the department to make the referrals. And then the department, DCYF, is obligated to engage in reasonable efforts to reunify parent or parents with child or children. For example, I have a drug court calendar at 2 o'clock today. We have a mother and a father, both substance abusing, right now doing very well, 3 children. And the last barrier right now to reunification is housing. No surprise to anybody. Housing is killing us in family court. And I think it's killing all social service agencies. There is none. It's too expensive. It's not safe. Hi.
Showing you?
Guess who's going to join me?
Hello, hi, friends. Oh, my goodness. Here,
I can sit.
oh, all right. Okay.
All right.
Okay. Jeannie, I want you to
Go
have a
ahead.
seat. Hi, everyone. Can you hear me now on Jeannie's machine? Hello, friends. Thank you so much. This is not my strength, but I honestly, I'm like the poltergeist with these machines. I guess I'm so glad to join in the remaining time, and I'm so glad to have this opportunity. And obviously, it's Magistrate Shepard who laid the great foundation in the history of the specialty courts. I guess what I would want to focus on is the piece where we kind of dovetail with safe and secure baby court, because I think that's really on point to the substance exposed newborn theme. And it really is a chance to highlight the benefit we have with these 2 courts, because we share actually the care coordinators who do the intakes, who are assigned to follow and track the cases for the families as they're appearing in court, be an extra resource, make referrals to the Department of Health, which has been wonderful in supplementing the traditional referrals provided by DCYF. But I guess what I'd like to focus on is that I have been educated so much about the fact that how easily it can be to collapse the idea that a parent has an active substance abuse problem when actually their child is getting classified at birth as a substance exposed newborn because they are benefiting from, meaning the parent is engaged with and benefiting from medically assisted treatment. And so we're all having a learning curve with this, myself included. I hope I'm making progress in recognizing that if it's buprenorphine or it's Suboxone or it's Methadone, yes, the child has to be treated because they're going to have withdrawal from that substance that was preventing the parent from being engaged with an illicit substance. And yet those parents then, despite all their hard work engaging in treatment, get lumped in as if their child was exposed to an illicit substance rather than a medicine prescribed to treat their addiction. So I'm so glad that we have the expertise of the members of the family services unit. Christine Monroe in particular has taken the lead on this issue, but also Julie Connolly. They sort of cross-reference for us between baby court and family treatment drug court so that they can flag, wait a second, this is a medically assisted treatment that's causing this child to quote unquote test positive. Their needs can be better served to support their recovery, to always be conscious of that issue, but they don't have the acute level of need that parents with a child, who has suffered from their active illicit use would have. So And then because we're working so closely together with Magistrate Shepard, I mean, recovery is a process. If somebody has a difficulty, then we can always say, gee, maybe you need the support of the Family Treatment Drug Court. You're not a good fit for us. So I think I am being reminded by Ray to use the questions on the side. I am not sure how to do that. Do you know how
It's
to?
Judge Leah, I'm actually watching the questions for you. Nothing's
Oh.
popped in just yet.
Oh, because I don't pause for breath. Okay, that's probably my fault. All right, so I guess when it appears, I'll see it in the side. I guess though that the unifying theme, even though we try to tease out the differences between the family's needs, whether it be substance abuse history, but in full recovery versus active need for the support of the Family Treatment Drug Court, is that both courts are trying to say, how can we make our services and what we offer fit you? We're not trying to put a label on the family. We're trying to offer them what they need. They need a shoe that fits their foot. It's not like you fail out of baby court because you have a substance issue that raises its head and you need family treatment. And it's not as if you can't benefit from the services of safe and secure baby court because you're in recovery. It doesn't mean you don't have other issues which might make you eligible for safe and secure baby court. I mean, as we know, being in recovery is just the beginning of solving all the other problems that probably exist with housing and a safe lifestyle and those type of things. So it's just, I love this partnership because I think it allows us to respond to the families in a respectful manner, and they don't have to repeat their story because we are working together. So that's kind of the takeaway that I'd like people to have, to make sure they understand that they can, a parent can be referred for an intake for safe and secure baby court if they are using a medically assisted treatment. And what I would really encourage for those of you who are providers and have access to families, to mothers and fathers who are expecting a child, the best possible thing to do is to come in and do an intake while you're still expecting the baby. No problem. Anyone can do an intake. I mean, I'm not going to have a baby. I'm 55, but I could do an intake and they'd have to do an intake for me. But so if you get out in front of it, and then it's easier to communicate with the hospital when that baby is born. Anyone can walk into the 3rd floor in the Garrahy building and say, I'm expecting, I've had DCYF involvement in the past. I want to get out in front of this. I am in a recovery program. I don't want to get lumped in with my history or the fact that the baby will test positive for the MAT substance. And I want to get out in front of this. Can do an intake. Okay. So, otherwise, I'm happy to take any questions. I just wanted to blurt all that out because I feel so rude I couldn't join timely. Are there any questions about any of this process? I'm just so delighted by the response. Yeah, I mean, well, we're like the two-headed monster here. I'm here with Magistrate Shepard. We're here together. Yeah, just trying to illustrate the point. We work very closely together, usually not on the same computer at the same time, but here we are. Are there any questions or anything?
Well, while we are waiting, so actually, one question did pop in. What would the process be if the person is incarcerated?
Okay, well, this is an issue near and dear to my heart because I was, in a past life, I was a social worker for a program for incarcerated mothers in New York, not here, and have also worked with incarcerated mothers here in Rhode Island. And there's nothing that prevents them from calling and scheduling an appointment to make an intake as soon as they're released. I think we would try to accommodate over the phone.
Yeah.
You know, we would bend over backwards. I mean, someone showing that much initiative who's trying to get out in front of that problem, that does not foreclose being, I mean, let's face it, we all learned to be flexible during COVID. So the idea that we can't accomplish something over the phone from Cranston, of course we can, okay? It's gonna probably require a little more legwork, but we're prepared to do that. I know that's true for Magistrate Shepard also. Please go ahead. Oh,
Sure.
all
So
right.
there was a comment just thanking you for recognizing and including fathers in the process. And then it looks like we do have a question. This person works as a clinical navigator on the family care unit and works closely with moms on the unit. Often there is DCYF involvement because of relapse during a pregnancy, and moms are devastated. Do all moms get legal representation? And is there a number you would suggest to call to support that?
They parents, moms and dads, and I very much include dad. Both of these courts include both parents. I think we tend to focus on moms because they're having the interaction at the hospital if they give birth, obviously, but and dads, please bring an ID to the hospital so that you can get on that birth certificate, because this is one of our biggest issues. My goodness, please bring that ID. I mean, of any type, just so that you can be included on the birth certificate. That's just a side in treaty that we have. But the legally, Magistrate Shepard or I can refer someone for counsel once the case is open. So the baby has to be born in order to create a case. I mean, this might be one of the only times where someone says, what, I have to wait for my baby to be born to be open to DCYF to be eligible for counsel, you know, and feels that that's frustrating, but that is the process we have. We can't assign an attorney for an unborn child, but as soon as they come in, and you know, this is something else. I mean, I don't mean to like devolve into legalese, which I know is can be very tough, but if you have someone whom you're working with, or you know somebody in this situation, they should immediately, if their child is removed at the hospital for one of these issues, they should immediately, the first day they come to court for that arraignment, that's the very first court appearance, just a fancy word for their first court appearance. They should request what's called a probable cause hearing. That's going to get them in front of a judge within 10 days by law, by statute, where they can have a chance to say, wait, I want to join baby court. I'm interested in family treatment drug court. My child is positive, but it's for a medically assisted treatment, not for an illicit substance. I want that to be noted. I deserve to take my child home. And I hate to use the word deserve, but you know, that's the language we're operating in a lot, especially when we deal with a removal at the hospital. And, you know, it gives them a chance to get in as soon as possible. So the magic words, probable cause hearing, please. Nobody is allowed to say no. Everyone is entitled to it. Nobody knows about it. So they don't ask. And then they sit there without their baby or any intervention until they get their first pretrial date with us, which is 3 months later. And as we know, that's an eternity for a newborn. Not to even speak to breastfeeding, which right now is my pet peeve, is parents who are unable to breastfeed because their child is removed, and by the time it gets sorted out, they're not producing any longer. So those are the magic words. I mean, you can have your baby and come down to the 3rd floor and schedule the appointment for the intake. You can say, my court date is next week. I want to ask for this probable cause hearing thing. Whatever that is, don't worry, we'll worry about that. But in the meantime, can I do an intake so that I'm also able to go in and say, I've been accepted to a specialty court. I want to join a specialty court. And that's not to say that they can't be serviced or have their case plan unfold on the regular calendar. I mean, these specialty calendars are voluntary. They're not for everybody. It sets a different pace. It has a different level of engagement expected from the parent, but that probable cause hearing is never going to hurt you. There's no downside to it. It allows us to hit the ground running. And, I guess the very unfair thing is because the parent gets referred for an attorney on the same day that they come in after the baby is born, how in the world would they even know to ask for such a thing until they have their lawyer whom they don't meet for 3 months, So if I had one takeaway from this, it would be do an intake as soon as possible and ask for a probable cause hearing at your first court date.
Can I just add something?
Yes, and please do.
No.
Yeah, no.
All right. The only other thing I want to add on that piece is if a parent comes in and is referred to the public defender's office of Rhode Island Legal Services, please, parents, please follow through. Go down to the 1st floor and knock on the public defender's office. Call Rhode Island Legal Services.
Yeah.
I can't do anything in drug court until there's an attorney appointed and the parents have talked to their attorney and agreeing to give up their legal rights. And that's a long, hard conversation. But if a parent doesn't follow through with the attorney referral, weeks and months can go by. And this happens, and that to me is the most frustrating thing because the lawyers are in the building every day.
I so agree with this. I mean, the thing that is most deadly to these cases is the passage of time. I mean, we want to strengthen that bond. We don't want a parent with a substance abuse history has their baby removed. They're living in, Siberia. They don't know what's going to happen. And that's exactly when they're going to be vulnerable to relapse. I mean, what is a more devastating time period, not to mention postpartum? If they're with an unsafe partner, that's all they have. That's them against the world. They're not going to court for 3 months. They're vulnerable in so many ways because they have the uncertainty of not knowing if they're going to get their child home. And so the sooner they can come in, do an intake. I mean, I'm fairly blunt, and I would say the same for Magistrate Shepard, if I may, that I say, listen, you're expecting, go do an intake now. I have somebody on my calendar for another reason. I'm like, why don't you, you don't have to do it. It doesn't commit you to do a thing. But same with the probable cause hearing. You could get there that day and say, I don't want to go through with this hearing, but I wanted to ask just so I could get a jump on my case plan. So, it's the passage of time that hurts that bond with the baby. And, we've learned so much about how crucial that window of time is in terms of the child's brain development, a million other things that I was very ignorant about, until getting a lot of training in this area. Now seems fairly obvious, but I guess it goes to show anyone can be taught. But I think we want to hear from you early and often. That's how we can get the case into one of these courts, or even just have it receive the appropriate attention on the regular calendar.
Judge Lee, I hate to interrupt. We
Yes,
have
please,
just over 3 minutes. We have probably time for maybe one more question. Just because I'm sure Margo shared, we're in a tight agenda today. But the question that I think might be maybe the quickest is, if someone has a history with the court but is in recovery and doing well and then gets pregnant and it's a closed case, should they expect a court involvement with this with the new child?
Well, I do not think they should expect court involvement. That's my personal and moral feeling. I feel they should be acknowledged for their recovery, and they should be treated respectfully because they're in a medically assisted program. But the reality is, at the hospital, there is the chance that they will get lumped in terms of having a substance abuse history and prior DCYF involvement.
Yes.
And you know what? It's more than likely going to result in a hotline call by the hospital. Now, am I faulting the hospital for wanting that belt and suspenders and wanting to say,
No.
geez, things sound great, but I just want to make sure because there's a history here and this is serious? I don't think it would be fair of me to fault that. I think, Magistrate Shepard recognizes that that's the case very often. So it may feel very unfair, but that's why, getting out in front of this and saying, listen, I had a history. I want to make sure when when the ladies pack that little bag to go to the hospital that has I don't know, I can't even remember all that stuff you bring when you're going to have a baby. Put your documents that show what you are doing in that bag. Make copies of everything. Make copies of your screens. Have that there and say, my name is Sue, and here's the program I'm in, and here's my screen. So I know my child's going to test positive for Suboxone, but I'm, get out in front of it that way, any way you can. I mean, life is not fair, but having a plan can make it get fair a lot faster.
The only other thing I'm going to add is, just because I've been on this calendar for so long, is DCYF has really changed since 2002. Prior TPRs will get you a petition, most likely. TPRs, involuntary TPRs, will definitely get you a DCYF petition. But previous dependent neglect, abuse, and reunification doesn't get a new petition all the time anymore. It used to. If there was any DCYF history, DCYF opened on the second,
Yeah.
third, and fourth
Yeah,
child.
that's
That
true.
doesn't happen anymore, which is progress. So that's a plug for DCYF.
All right. And actually, I'm just getting the heads up that we're actually at time for this part of the time. So what I was going to do, if it's okay with both you, Judge Leah, and Magistrate Shepard, I was going to pull the questions that we weren't able to get to, and I'm happy to send them to you if you're open to that
Yes,
follow-up.
We can do that.
Absolutely.
Thank you
Yes.
both so much. And I appreciate you, Judge Leah, for your persistence to joining us. So thank you for that.
Just a final word. There are so many excellent people in the state working on these issues. I mean, I agree. It has come such a long way from what it used to be, but you know, it's almost like we developed the medically assisted treatment and then we got to learn about a new thing, but that's
All right.
okay.
This is what success looks like. This is the cover of Amos House. It just came out. That is success. Okay. I'm not going to say who that is, but that's my case.
Thank you so much.
You're
Thank you,
welcome.
everyone. Thank you.
you
We are
both.
here. We're available. We're here every day.
All right.
Walk-ins welcome.
We're both gonna leave because we both have
Okay.
calendars.
All right. Thank you so
Okay.
much.
Thank you
Bye.
both.
Bye.
But much appreciation. Thank you so much. So onward, our next speakers, we have another group. They're not in the same room, but I think they're all on their separate calls. Let me begin my introduction. Stephanie Terry has a BSW from Providence College and a MSW from Rhode Island College. She began her longstanding career at the Rhode Island Department of Children, Youth, and Families as a caseworker. Since then, she has been a supervisor, the Child Protective Services Administrator, and currently serves as the Assistant Director overseeing Child Protective Services. Katie Gonzalez is a certified peer recovery specialist, supervisor at Parent Support Network of Rhode Island. Her work with pregnant and parenting women with substance use disorders is informed by her own lived experience with substance use, medication-assisted treatment, and recovery. She is certified by DCYF to supervise visitations and is a member of the SEN Task Force. Katie is working toward her degree at CCRI and her certification as a community health worker. Sean Warren is a certified peer recovery specialist and certified community health worker at Parent Support Network of Rhode Island. He is also certified as a connections facilitator by the National Alliance on Mental Illness, a nurturing fathers facilitator, nurturing parenting facilitator, and a medication-assisted recovery support group facilitator. He is a member of the Rhode Island Fatherhood Initiative at PSN and a recovery consultant at Foster Forward. Sean is working toward his degree at CCRI. One more. Liz Anna Darling is the clinical director at Parent Support Network of Rhode Island. She has 3 master's degrees from Rhode Island College in agency counseling, substance abuse counseling, and co-occurring counseling. She has a certificate of advanced graduate studies in mental health counseling. She is a licensed mental health clinician and a licensed chemical dependency professional. Lizana has over 20 years of experience working with children, adolescents, and adults who present with mental health and substance use disorders in various settings, such as residential treatment facilities and community and state agencies. Stephanie, take it away.
Hi, good afternoon. Thank you for having us. I'm gonna try to use my technical challenges and start sharing the slide. I just want to say it's an honor for us to be here and really talk about the changes and the practice shift. And it doesn't only need to occur within DCYF, the real shift needs to happen well beyond us for really to help families the way we want to help families, the right way. Practice has changed very much over the many years that I've been with the agency. I'm going on 34 years in this field and in this department. And as the judges spoke about, there's been a lot of changes. Families that we look at today and do safety plans and may not even open the case for investigation and screen out the report are families that 15, 20 years ago would most certainly have been open to us. The way we look at medication-assisted treatment now versus the way we did 30 years ago is very different. There was an expectation that you be clean, completely off everything. It really wasn't recognizing substance use disorders along with other mental health, behavioral health disorders. It's not a lifestyle choice. It's not a preference. It's not a conscious decision. And I think that practice has shifted so much. We still have a very long way to go. And again, it's not just within DCYF, it's the outside, it's the entire community. So what I'm going to talk about today is the incredible work with our peer recovery specialists and Lizana and her supervision of the program. We couldn't do any of this without them. They are truly the heroes and the champions here. And as we go through the slides, I'm going to talk a little bit quickly about how we evolved to this and how this fits into our overall practice model. So what we're talking about today is supporting families affected by substance use disorders through our peer recovery specialists, the Rhode Island Safe Practice Model, and a collaboration between DCYF and the Rhode Island Parent Support Network and the Rhode Island Department of Health. So background, by law, we cannot investigate allegations involving a pregnant woman who has no other children. So recognizing the risk to substance exposed newborns, back in the early 2000s, we developed in the criteria, which was promulgated, what's called a pregnancy alert. It was added to the Rhode Island statute, which establishes the criteria for what we investigate. These hospital alerts were sent to birthing hospitals without specific information, basically saying, we have information about this family, and if this mom presents at your hospital, please call the hotline. We who were behind this legislation really wanted to see, in addition to notifying the hospital, the purpose really being an outreach to the family of saying, what can we do for you to prevent our further involvement and to ensure healthy newborns and give every opportunity to not have to remove a child from home or intervene. There was a lot of pushback at the time around pregnant moms in particular. There not actually being a child to investigate. Some states at the time went the complete right of this and investigated pregnant mothers. There were prosecutions. There were all kinds of crazy things going on nationally at the time that we didn't agree with. So we kind of halfway stepped into the water, but not all the way. So we agreed that, yes, we wanted to notify the hospital, but we didn't feel comfortable outreaching. And it's something that I always felt that we really should have been doing. Fortunately, as our mission and goals have kind of been revised to be much more family friendly, to be much more recognizing of behavioral health and health equity, and substance use disorders in particular as being behavioral health issues, not lifestyles or choices. We finally made a decision and took a position under Acting Director O'Coin's guidance in 2019 to actually outreach these families, which is a pretty interesting conversation that I'll get into a little bit as we go along. So really the goals of all of this work is to engage families in a meaningful, transparent, non-judgmental way, reduce the stigma, and create a network of natural and formal supports to reduce the need for out-of-home placement, expedite reunification when children can't safely be maintained in home, and overall improve outcomes for substance-exposed newborns and families. So we have regularly scheduled weekly case reviews at least once a week of all of our substance-exposed newborns and moms. We have hired or rehired a DCYF substance use disorder liaison. We had the position back in the mid to late 90s, all the way through until the early 2000s when this person retired. And we were making some progress. We were involved with the Department of Health. We were involved with the HTDH and what we call the Project Connect Coordinating Committee, really looking at best practices. And it was those folks at the table that really pivoted the opinion and the way that we were dealing with families who were on medication-assisted treatment. Because prior to that time, again, we were pushing people to go be clean, quote unquote, to not be taking any medication. You certainly wouldn't ask someone with a cardiac disease or with diabetes to stop taking their medication. So we were beginning to shift that focus. We were developing with the community programs for moms, Project Connect out of Children's Friend and Service, Starbirth. There were other programs. We also now have Amos House. So it was really beginning to shift that culture, but we never actually embedded it, and it was never really a formalized piece of practice with stopgaps and points during the trajectory of a case or a report, or when a family crossed our threshold to really ensure that. These things usually happen once the child was born, once we knew that we had someone within a substance use disorder, and then usually children were removed. So these were efforts to put them back home and keep them home. But it really eliminated that prevention piece, prevention from becoming involved with us, prevention from being removed from home. So this really formalizes that. So our substance use disorder liaison also works with social work interns. We don't have any this semester, but we did last year. We do case reviews. Child Protective Services is represented. DCYF family service units are represented. The birthing hospitals are there, and we have information that the hospital may not have, and the hospital may have information that we don't have. So it's really being comprehensive and looking at this family from every point of information that we have and point of contact, with the shared goal of ensuring a healthy delivery, a healthy family, and reducing the likelihood of removal. What do our peer recovery specialists provide, and what does our SUD liaison help with? Referral for detoxes as needed, residential treatment referrals, mother-child programs, MAT referrals as appropriate, intensive outpatient, peer recovery specialists, and referrals for basic needs, because very often that goes along with the issue. Housing is a huge crisis in Rhode Island, as I know in other states as well. Parent Support Network is providing us with the peer recovery specialists. And as I get through this, I want our peer specialists to talk about their experience, which is another piece of a shift in practice, because as Margo said, our folks have had life experience. They've lived it. They've gone through DCYF. They've come out on the other side, their successes, and they have so much to share and so much credibility and empathy out in the community than when they're working with our families. They can deliver the same message that I deliver in a very different way that's seen as much more supportive, as opposed to always that threat of what else is going to happen. Are you trying to get me to disclose this because you want to take my children? It's quite the opposite, but they help us message that. They have a way of really helping engage and motivate a family that we would never, ever, ever happen, just by virtue of who we are and what our requirements are. So having said that, many, many years ago, the response would have been, oh no, they have a history with DCYF. We can't have them doing this. Where now we're actually seeking out folks who have history, who have lived life experience, and who can really message and support families ways that we cannot. So that's also something that I'm very proud of, that we're thinking differently about, and really had this rich resource for many years and didn't draw on the way that we should have. So we began the program using some of the opioid recovery money, worked with BHDDH, Lori Dorsey, who's not on, a few others were really helpful with us and the Parent Support Network to get the startup funding for this. We need more coaches than we have, that's clear. We started this out in Child Protective Services because that's the beginning. So we're able to make calls on those moms who haven't delivered yet. We're connecting at the hospital with those pregnant moms. These folks go out with our investigators on investigations or during the investigation to reach out to the family right when the crisis is there, and we can make some change, and we can try to safety plan and connect families, with other family members, with other community supports. We call them natural supports. It's that network, it's that safety net that we all have that keeps us from getting involved and keeps us from being in crisis. A lot of our families don't have that because they're embarrassed. They don't want to share that they're in crisis with family members. They may be estranged. There may also be multi-generational issues. There may be the reality that families don't have a lot left over to give to other family members who may be in crisis. They just have what they need to be able to help their own family. So there are a lot of reasons and a lot of dynamics. And this also helps with bridging that gap and helping families to develop these networks of support. So I'm not going to talk about what our recovery coaches do. I'm going to have them talk about it. But we work directly also with young adults between 16 and 22, active engaging families. This is voluntary to provide support and education. Families don't say no. And I've seen these folks really try to track people down that we're very concerned about because they may have initially agreed to participate and then they fell off the radar, and we know that they're in trouble. They are relentless with trying to find them and get them the services and the supports they need in a timely way. So we provide an offer of help to family members and pregnant women who use substances. Individuals have to be ready to accept help, but if you say no the first time, that doesn't mean that you can't come back, and doesn't mean that we can be a little bit relentless with offering the support. Connecting people with lived experience with individuals whose substances impacts the stigma of substance use. It really is a cultural shift, but again, it has to be absorbed by the entire system. So I'm gonna stop sharing and we can have our peer coaches and Lizana start to jump in and maybe take some questions. I want to add another piece to this that is really critical. This is part of a much larger effort, which is referred to as the SAFE, Rhode Island SAFE. It's Safety Assessment through Family Engagement. In 2019, DCYF contracted with a provider, Action for Child Protection, to actually develop a service model. So we have a practice model now. We were practicing from a practice model from 1984. So if you're from Rhode Island and you use the word CANTS, we haven't had, CANTS is not even what the division was ever called. It's the Child Abuse Tracking System. It was the name of the computer. At that time, the division rolled out with a retired law enforcement. So it was a very different approach. It was about an incident, and we decided whether people are safe or not based on whether an incident happened or not. And that's not what determines safety. Incidents inform it. Incidents are how we determine whether to get in. However, we now do what's called a family functioning assessment. Our investigation time for completion has gone from 30 days to a maximum of 45. It used to be 10 days to 30 days. So it's much longer, recognizing that it takes time, particularly when folks are contemplating recovery. It's really based on the model of stages of change. There are tools and checkpoints along the way. There are requirements that really are about engaging community and family and assessing families. You may have a substantiated CPS investigation, but not an unsafe situation. On the other side of it, you may have an unsubstantiated situation, but not a safe situation. So it's less about whether we caught someone doing something right or wrong. It's more about really assessing people today and what do they function like on the ongoing. There was some questions about if a mom is in treatment and would we be reported? Sometimes they still get reported, but it's really up to us to determine whether we screen those reports out or not. So let's say I'm on Suboxone, I've been in treatment, I've been in recovery, maybe I had a prior termination. Does that have to be called in? Well, if something's not going on right now, it's really about whether or not there's maltreatment now. Having said all of that, do we get these reports? Yes. Would we screen it in? It depends on how long ago and what the other dynamics are of it. But someone just in treatment who doesn't have a history like that and is doing well and there's no concern for maltreatment, we wouldn't investigate that situation. Years ago, would we have? Yep, we would have. We definitely would have. But it's medication, it's treatment. There were a lot of these moms when we began to do these outreaches on the pregnancy alerts. So back in 2019, Peter Sloan, who's since retired, really pioneered this with us. He was great. It's a big loss, but Dorcas has replaced him, and she's great. She's coming up to speed and she's getting it. She's on maternity leave right now, but she would have been here today. One of the things, we made the first call. So we called this mom who had 6 prior terminations between Rhode Island, multiple states, and Florida. And I said, I'm Stephanie Terry. I'm calling from DCYF. We got this information. And she's like, what? I said, don't hang up. It really is DCYF. I said, I'm going to give you the hotline number so you can call there and confirm. You're the first call that we've made. We have what we call a pregnancy alert. We know you have a history. Florida called us. We're aware of it. We want to know what you need so that when you deliver this child, we have a healthy baby and we don't have to intervene. She thought I was out of my mind. She called the hotline. She confirmed who I was. She let me talk to her. We hooked her up and we got her into services. And she and her partner, the baby was not removed. We had another mom right after that who was in really, really bad shape. She had overdosed twice while she was pregnant. I'm sure that she would probably not still be with us. I believe Katie helped. We got her into treatment, got her into Starbirth, and had a very different outcome. So, but that is really, and I've had to convince my peers and my fellow supervisors and that this is the right thing. And we're very liability based. Something goes wrong, we're plastered all over the paper, whether we knew about it or not. I'm not going to say I don't care about that, but I don't care about that. For me, it's about doing right by the family. And if we've followed the practice model and we've done the right thing and given them made the right safety decision, and we allow the process to follow itself and don't go in there with a preconceived decision, I think that takes care of itself. I think that that's what does the right thing by the family. It's a best practice, but it also, for those staff afraid of the liability, it also covers that liability because you haven't gone in there, just deciding, gee, you get to keep your kids and you don't. It doesn't work that way. I think that leads to a lot of things being inconsistent. Some families saying, well, I wish I had you as my worker because my worker did this. I have to humbly say that looking back on my practice 34 years later, there are families where I would have removed the children and families where I would not have removed the children. And accessing services today is so different. I can remember having to go to Benjamin Rush over on the grounds of the Pastore complex to detox. And my moms had to be actively drunk or high and taking them out. And I was a very young worker, taking them out, coming back to get them, knowing they were under the influence and having to take them there and crossing my fingers and hoping that they would be back there to meet me when I was going to drive them back and that I didn't lose them, that I really was going to get them to make it all the way to the ER to get into detox. That's a horrible, horrible way to do things. And I remember I'm a horrible driver and I can't see. And it was a bad thunderstorm. And my mom looked at me and said, thank God I did something before we went because your driving is scaring me more than anything. So those were the things we did back then. But now, fortunately, we don't have to do that anymore. And no one has to wait and no one has to be afraid. I saw a question quickly about plans of safe care. In Rhode Island, if you have a substance exposed newborn where there's no suspicion of maltreatment, no other factors, you don't call the hotline, those babies are reported to us in an aggregate that's not identified because the feds require the reporting. Only the reports where there's a suspicion of maltreatment, or even if the family needs a little something else, and it's really not maltreatment, that's not unusual. We have a screening and referral unit. Sometimes those calls will come through the hotline, and then we may directly refer the family to the family community care partnerships. We have 5 in Rhode Island. It's a care coordination entity that we fund with a wraparound service model, or they may be open to briefly to the service screening and referral unit to hook them up with whatever it is that they need. Lately, unfortunately, most often it's housing. So I'm going to stop so my partners here can jump in and see if any questions.
Thank you, Stephanie. Hi, everyone. My name is Lizana Darling. As Margo said, I am the clinical director at Parent Support Network. For those who don't know, Parent Support Network of Rhode Island is a peer-driven agency. And when I met with Lisa Collin, who is the CEO, I was a little confused because I didn't know where I fit in. And very briefly after, and with all these programs coming out, I found myself fitting in. A lot of people, I'm a licensed mental health and substance abuse clinician, and I see privately my own clients. But my role at PSN is dedicated to the staff. So they're peer recovery specialists, they're parent partners. They went through a lot of personal experience, and my job is for them. I want to make sure that my staff is going out and taking care of other people, but they're also stable in their recovery and they're doing what they need to do. Just recently, we started at PSN an awesome wellness program for our staff, or our own staff. So part of my job is to sit with them and have clinical supervision, go over the referrals, talk it through. And sometimes, at the beginning, I remember some people being confused between a psych eval and a neuropsych eval, and they would send them to a psychiatrist or a therapist, not knowing. So being able to be there and help out the staff and know those clinical terms and how to help them, because they might be affected by substance abuse, but most of them also have that co-occurring. So kind of directing them and going over our clinical supervision and going over the referrals kind of helps them know what to do out there in the field. I don't really want to take a lot of time because Sean and Katie are they're both managers. They were recently promoted to managers, and I love working with them. The passion that they have working with families that have, mental health and substance abuse problems, it just blows my mind. Stephanie says it all the time. We're on the back, but the people that really make up the show are the peer recovery specialists. They make those, recovery happen. As I said, as Stephanie was saying, I worked for many years with Peter Sloan and recently with Dorcas. And I'm going to talk a little bit briefly about the referral process. So what happens is there are many social workers, DCF social workers that send a referral to Dorcas. At the time it was Peter Sloan, but send a referral to Dorcas. Dorcas will go over it with me. And I would basically coordinate with these two wonderful people, Sean and Katie, and go over the referral and see how, if we can match any of these referrals with an appropriate peer recovery specialist. We have 7 as we speak, including Katie and Sean, peer recovery specialists that work on the team, and they have different past experience. So we have people that have experience with MAT, people that have experience with substance abuse. We have people that have worked in detox facilities. So they have different qualifications and expertise. So when I do receive that referral, the first thing I do is sit down with the team and say, okay, what is the best match? And usually I leave it up. Sean right now, unfortunately, he's the only male that we have. We're in the process of starting with the new intern, and hopefully we will hire him. But he right now is the only male CPRS that we have, and all male referrals get to him. And believe it or not once I've seen or heard Sean complain or sweat over the big caseload that he has. He's always on top of it. Katie's very familiar with our team, with the rest of our 4 or 5 staff, and she knows exactly who to refer them, and she'll give feedback about how maybe Sue is more appropriate or Charlotte is more appropriate. And we do this via email. There's no reason for us to meet. These are referrals that have to be met within the 24 hours. So we try to meet them, or at least I'll reach them via phone within the 24 hours. So I'm going to give the baton to Katie and then to Sean. And you're basically going to explain what happens once I give you the referral.
Hi, everybody. So when we receive the referral from Lizana, it gets assigned to the peer. We make the contact within 24 hours, and then usually within 48, we already have our intake scheduled. We set up an intake date. We kind of fill the social worker or investigator in as far as, when our intake day and time is, and of any services that they feel that they would benefit from, depending on their case. So the hospital alerts that we started doing are amazing. When we get the hospital alert, instead of no baby, no case, we're able to jump in before they deliver, which I've had a few cases, well, one in particular where this mom was due in about 3 weeks, who had a few positive fentanyl screens. So I got the referral, called her right away, met with her. I got her involved with an IOP program at Women's Day. I got her involved with First Connections, and by the time she delivered, she was able to take the child home on a safety plan. So those are the results that we love to see. Unfortunately, we still have some barriers where providers won't report to DCYF of a pregnant mom using, whether or not she has children at home. So unfortunately, with those cases, we get them after the fact. The moms go and deliver, and then they're like, even though they knew they were using the whole time, they're like, I didn't see this coming. Why is this happening? Why can't I take the baby home? And then unfortunately, when that's a situation, it could take, 6 months to a year, whether, if they're in foster placement. So definitely the earlier the better. When I work with pregnant moms, I meet them with a RAD. It could be just a mom who's stable on her MAT. She may need help with say WIC, food stamps. We are allowed to transport parents, which is good. I think it builds that connection with us. You know, if we get referrals from moms that are actively using, it could be to, you know, methadone, inpatient, detox, you know, whatever the case may be, depending on what they want to do for their recovery and, you know, where they're at. So I come from the experience as I had my daughter on methadone 5 years ago. And during that time, I felt unsupported, even though I had a husband who was in recovery also. He didn't understand the whole methadone piece of recovery. He would frequently be like, why can't you just stop? You know, you're going to hurt the baby. It's going to have withdrawal. So we often argued about that. And I was the type at the time that, you know, the higher the number, the more likely withdrawal is, because I just didn't know what I know now. So now that I take my personal experience and what I've learned throughout the years, I'm able to connect with these moms who, you know, were feeling the same way I did. And, you know, unfortunately, it's still extremely stigmatized. You could be pregnant, walk into the methadone clinic. Other people will judge you even though they're on it. You know, 12-step meetings. So it's definitely good support to actually talk to somebody that's been through it. And as far as if I meet a couple, that's where Sean comes in, because we frequently have couples say they're one or both are using. And if they do plan to stay together and they plan to safely plan together, it's kind of difficult to get one to treatment if the other one doesn't want to jump on board. So I pull in Sean for the dads frequently. So I'm going to send it over to him. Thank you.
With Sean coming on, nobody has fathers up until recently. All these cases, these petitions come through, dad is unknown. Sometimes they don't ask. Sometimes DCYF in the computer system has historically tracked by the mom, because mom's delivering, it's one mom, could be different dads. But there are dads out there that don't know what's going on. And to Katie's point, their partners may not be in the same place in terms of recovery. And we lose that opportunity with dads. And we always assume that, you know, dad's over here and mom's here. A, don't assume, and B, it shouldn't be that way. So that's why it's so great to have Sean on as well. So sorry. We've got
No, please.
9 minutes. I'm supposed to be watching time.
All right, it's all right. Thank you very much for the introduction. And yeah, very much so, Stephanie. First of all, I'm Sean Warren, certified peer recovery specialist with Parent Support Network. Yeah, a lot of great information that was being shared. You know, I'm over here just like jotting down, you know, even though I'm in the field on a regular basis, I'm jotting down notes on like processes and like the probable cause hearing. Different resources like that, I think, are invaluable, really. And I think that's why like these meetings and these you know, presentations are so important. Yeah, as an individual in long-term recovery myself, as a father who lost his children to DCYF, you know, conceptualizing being able to actually heal that relationship that I felt, you know, like really harmed me in the past, right? Because it wasn't pretty that my experience with the DCYF. It was pretty much exactly how it was stated. Hey, you used at one point at some point in your life and anywhere, when with or without the kids, maybe kind of. Oh, you did? Okay, kids are gone. Like it was really like that simple. It seemed as if it was you know, open and closed, and I had no voice, I had no support, there was no advocacy, there was no direction, there was no you know, there was no understanding of the process. It was so convoluted. I was confused, scared, lost, and on the brink of death, right? Because I really was at a point where, like they had shared, that is a place where you're at your lowest, and relapse is like, or reoccurrence, I guess, is very likely. You know, being blessed with the opportunity to work in the field under you, Stephanie. Lizana is incredible. Katie's an amazing partner. You know what I mean? I have such amazing, powerful women in my life. Says the story. Ask my mom. And you know, like being able to actually be out in the field and represent like the DCYF in this way and Parent Support Network in this way, and then also just like the general field itself in a way that's like very loving and empathetic and very relatable, which is what I consider myself. Being able to actually be out there and see the impact that this you like this mission that we have here is actually having on families is so beautiful. And particularly, in my case, being able to work with like we have something called the Rhode Island Fatherhood Initiative. It's an initiative that's actually national. It started in the 60s. It started based off of, if I'm remembering correctly, it was in the 60s, and it was all about like marriage and divorce controversy and like what the role the father played in the family, right? And so fathers have been, historically monetized within the family, within the household, right? Like, hey, you're a provider, you're the breadwinner, right? As far as fathers and nurturers weren't, you know what I mean? It was actually like the role didn't even apply to one another. And so, with this fatherhood initiative group that we have, it's like the idea and the intention is to create a safe space for men to come and like learn a little bit about what they're, like to just find value in themselves, right? Come and create a unified connectivity, like a connection, a community of people who have experienced the same things, and empowering these fathers to be, empowering them as the nurturers that they are, not just providers financially, but also nurturers. I mean, the role of a father in the child's development is critical, right? Like if you look at the statistics and like the success rates for families and children in single parent homes, they're far less when the fathers and, when the parents aren't together, but when the father, I guess when I say when the parents aren't together, but, father's rights and fathers being primary caretaker in the home is something that's really new. So when I say that, it's like when a family aren't together, when the fathers aren't in the home, the success rates for those children in that home are far less. And it's not just about like empowering them, and it's about reducing the stigma, not just the fatherhood part, but just like the stigma, the generalized idea of like men not being able to share their emotions and experiences and really focus on voicing their mental health concerns, being able to provide them with that space and to allow them to like, they share their feelings and their experiences. And through that, they are able to like share resources in that way through sharing those experiences. And then like those resources, whether they be financial, like it's just a greater access to services for men just due to this one group, which is like, or this, not one group, but like this whole movement, this initiative. And so allows them a greater access to services just by the know-how, the knowledge. And then on top of that, using fringe therapy, talk therapy as a form of therapy has been like well recorded, known to be very, very beneficial when it comes to psychological and physiological effects, right? Reducing stress, reducing anxiety, reducing risky behaviors. I mean, if you look at the history of talk therapy, if you look at studies that are done, they have a study now that's 5-year study, and it shows that after a year of talk therapy regularly in somebody's life, the likelihood of them like reattempting a suicide is 27%. It reduces that likelihood by 27%. And after 5 years of the same individuals being in the same type of talk therapy, it reduces that. The statistics, I think, is like 26% after 5 years. The likelihood of suicide reoccurring is reduced simply by talk therapy, right? So just like creating a space for individuals to come together to create a community, to really focus on those 4 corners of recovery, which is like, home, health, purpose, and community. You come to these places and you find what is like a removed family, like family you choose, right? And it offers you this knowledge, this know-how on how to build yourself socially, how to build yourself financially, how to build yourself spiritually within the home as a father, as an individual who deals with, substance use and mental health complications, these co-occurring disorders, which I think is, that's the key, what's it, a coined term now, right? Like the co-occurring disorders, like, yeah, I won't get into my personal beliefs, but either way, I feel so blessed to like, be a part of this movement, to be here. Stephanie, you invited me. It was late in the game, but you know what I mean? Like rather late than never. And that's the way I see it. I mean, and that's how I approach recovery as well, right? It's never too late. It's never too soon. Those individuals out there that are seeking the treatment, seeking the help, seeking the connection, seeking the love, like that's what we do here at Parent Support Network, arms wide open.
I want to interrupt you for a minute.
Lisanna, Lizana, we're actually at time. So if we could do the last 60 seconds to wrap
Absolutely.
up, I
I just
apologize.
wanted to share with everyone, because Sean had mentioned that he was involved with DCUF and he lost his children, but he is a proud father who has custody of his children at this time. And just like every father, single, father, he struggles, but we support him and he's doing amazing, doing the right thing for those boys.
Yeah, thanks, Lizana. Yeah, it's been awesome. I'm blessed endlessly.
I just want to say how impressed I am and how, I mean, these two are young compared to me. So the excitement, the energy they have that they put into this, not that Lizana's not young, what I mean.
I put in my dues. I already paid my dues. Now it's up to them to go.
Well, that's it. And I'm so proud to see how much they've grown professionally since they started. I remember interviewing you in my office, Sean, and meeting with you, Katie, and meeting with a few others. And it's amazing that was 2019 and this is only, going into 22, but how far you've come along professionally and how much good work we've done and how the referrals have really increased since July or so. And I just want to say what we saw at DCYF during COVID was more relapse and substance use disorder and mental health and depression than anything else. With schools closing, everybody was worried about these poor kids behind closed doors. It really was the stress the parents were undergoing, and the emotional and the mental health that the entire family was feeling. That's what we saw, and that's why this work was so critical.
Thank you so much, guys. Terrific work. So appreciate your collaborative and collegial, the relationship that we have, and hope that we keep it going. I'm now going to let Christy introduce me.
It's a great way to get introducing me to introduce you. All right, so as Margo indicated, I get to introduce our final speaker for the day, which is Margo Katz. Margo is responsible for the planning, implementation, and administration of the Substance Exposed Newborns Program at the Rhode Island Department of Health. In her role, Margo co-chairs the Rhode Island Task Force to support pregnant and parenting families with substance-exposed newborns, otherwise known as the SEN Task Force, and manages the statewide implementation of the Plan of Safe Care federal mandate. Margo came to the department after a nearly 20-year career in hospital-based healthcare, where she led programs in infectious disease and biodefense, cardiovascular disease and stroke, and graduate medical education. Wow. She has a bachelor's degree from Hampshire College and a master's degree from Smith College. And with that, Margo, I am happy to hand the baton back over to you.
So I'm going to wrap up this conference by talking to you about what's going on in Rhode Island, the big picture, the big Rhode Island picture. So we have about 10,000 births a year every year in Rhode Island. I just said that. And about 5% of these births are newborns who've been exposed to substances that have the potential to impact their health and development. We call them substance exposed newborns. About 20% of our substance exposed newborn cohort have a neonatal abstinence syndrome diagnosis, which means they're experiencing symptoms of withdrawal. A snapshot of maternal substance use in Rhode Island. You can see that this is mostly white, not Hispanic, living outside of the core cities. The education is basically 12th grade or higher, most on public insurance, most are between 20 and 34. And marijuana is a huge, huge exposure in Rhode Island. There's a prevalence of women who are pregnant and use marijuana. And you can see that methadone comes in second, and those are just select exposures. So we have a Rhode Island task force to support pregnant and parenting people with substance exposed newborns. We call it the SEN task force because that's a lot of words. We have a strategic plan that we put together before the pandemic. And you can see our 4 pillars there, and throughout our pillars is safe and bias-free care for all runs throughout everything we do and everything we talk about. The members of the SEN task force come from all professions, all disciplines, hospitals, the community, nurses, doctors, substance use treatment providers, public health, DCYF, and we exist in the nexus between early childhood health, perinatal health, and behavioral health. So as I said, the overarching goal of the program that I manage at the department is to improve the biopsychosocial health and well-being of women who use substances and their substance-exposed newborns using the social determinants of health and racial equity lens. What does that mean? It means that we don't all have a fair and just opportunity to be healthy. So we're not all the same. There's racism, homophobia, transphobia, and so many other oppressions that are sewn into the fabric of our society and our culture. Thus, we have different lived and felt experiences, and all of this has to be taken into account when we're providing care and we're talking about policy that is meant to support these families. I'm going to share with you 3 select goals and activities that we've been working on in the past 4 years now. One is that the task force is very interested in universal screening for all women of childbearing age for mental health and substance use. The long-term path to this is going to Medicaid and going to the Office of the Health Insurance Commissioner and saying, hey, we need performance measures. We need providers to be reimbursed for screening so that everyone can get screened. But that's not going to happen today, and it's not going to happen tomorrow. So instead of waiting around for that to happen and doing nothing, we're trying to do it programmatically, one practice at a time. One of our most important partners is the Rhode Island Moms Psychiatric Resource Network, Moms PRN. They have a hotline, a provider-to-provider hotline. Physicians can call if they have a woman who has behavioral health issues, they don't know what to do, and get some one-on-one guidance, so consultation. But they also have a learning collaborative where they have a cohort of practices, OB practices. This year they have a substance use treatment provider, VICTA. But generally they want to improve the use of screening for depression, anxiety, and substance use. And they also want to improve the quality of screening. So it's about teaching how to screen, supporting providers in screening, and getting us to a baseline beyond 0. So you can see here, again, my eyes, that before the cohort, providers were only screening for depression. Afterwards, the depression screening rose, anxiety screening appeared, and so did substance use screening. And the results of that first cohort were that 20% of the substance use screens were positive, 9 for depression, I think, and 17 for anxiety. So that's one way to improve and enhance screening with OB providers. This is really interesting. The SEN task force recently learned, was given a presentation about PRAMS data. PRAMS is Pregnancy Risk Assessment Monitoring System. It's a survey that goes out from the CDC Rhode Island participates in this. Women who've just delivered, a certain percentage of them get a survey in the mail. It's a paper survey. Tons and tons of questions, pages and pages of questions. Some of them have to do with safe sleep. Some of them have to do with substance use, et cetera, et cetera, et cetera. What we learned from recent PRAMS data was that more Black and Hispanic women and those with less education reported being screened for illicit drug use, and more white women and those with higher education reported being screened for the use of prescribed medications. So this is telling us that the bias that we always knew was happening, we now have proof of it. It's like proof of the pudding right here. So this further informs our interest in universal screening for substance use and mental health. Early identification equals early intervention. It gives women a chance, gives pregnant individuals a chance to right the ship before they deliver and before DCYF comes in. Also other interventions like therapy, like medication, MAT, and I'm talking about mental health and substance use. However, this can be perilous. It can feel perilous to women who fear incarceration and the repercussions of child welfare, which we just talked about. So as we move toward universal screening and continue to advocate for this, The policy and the practice that we're putting forth, they have to be protective and not pejorative in the absence of child welfare concerns. If there are child welfare concerns, there are. But if there aren't, and the families are trying to do the best they can, we can get them into treatment, we can get them into therapy. That's what we want to do. Screening, however, is useless if it's not universal. So, but universal screening has to also be supported by teaching providers how to screen practically, how to refer to all the supports and services we've been talking about during this conference, and then how to recognize, check, and eliminate their own implicit bias, because we all have it, and consequently the discrimination that comes from their actions in their own practice of medicine. And that's a heavy lift, but it can be done. I'm convinced of it. The message I want to be hearing in doctors' offices is, I'm about to ask you some questions. We ask everyone these questions. Okay, the next one. Decrease the number of women who experience fear and discrimination due to bias and stigma. I'm going to talk to you a little bit, some of you have heard this ad nauseum, about our Substance Exposed Newborns Media campaign, the first of its kind in Rhode Island. We wanted to leverage paid media to let pregnant women with substance use conditions know that there is help out there for them. We wanted to encourage them to engage with Parent Support Network's peers, Katie, Sean, everybody that we just saw. It's a great program, and this is a specialized cadre of peer recovery specialists, and so important that women who with substance use conditions know that they're out there and they can connect. And we also wanted to, in our images and in our words, ensure that there's empathy and hope. And then especially in the images that we showed, diversity and equity. I think I might have said that already, I don't know. So we held, first of all, I hear the garbage truck coming, so that means the dog's gonna bark. We started this before the pandemic. And when the pandemic hit and I got pulled into COVID and everyone else got pulled into COVID, we stopped. When we came back to revisit this in late 2020, the world had changed so much, we needed to start at page 1. So we held 3 more focus groups with 16 participants, Parent Support Network, our friends at Project Weber Renew, great organization, Amos House, fantastic. 25 to 45-year-old women showed up. They were white, Black, or multiracial, and some identified as Hispanic. The criteria for being part of these focus groups was that they're currently using or considering getting pregnant, they have a current or past use of substances during pregnancy, or they used during the first 5 years of motherhood. What we learned was so beautifully simple. Confidentiality is key. A lot of these women, depending on the substance they're using, are afraid. They avoid medical care, prenatal care, and they have a deep fear of DCYF. We also learned that the state is not a trusted messenger. If we had the RIDO logo on there, nobody would call. Hospitals are also not a trusted messenger. We learned that as well. The other thing we learned is that judgment-free help is super meaningful. We know that judgment fuels shame, shame fuels isolation, and isolation means bad outcomes for both mother and child. So we wanted them to know that the peer recovery coaches were there for them, men and women who have walked the walk and talked the talk. We also learned that moms wanted to see themselves in the ads, young mothers, newborn babies. We learned that a mother in a t-shirt with her hair a little messy is way more relatable than a mom in a bathrobe sipping a cup of coffee who codes as affluent. We also learned that they didn't need to be told that they shouldn't be using substances while they were pregnant. They know. They didn't also want to know about the dangers. They know. The other thing they told us is that it's not just opioids anymore. And we know that we're in a polysubstance use crisis. It's everything from nicotine to methamphetamines to fentanyl. So we didn't want to exclude people by just giving an opioid message. We opened it up to all substance use. So our primary group was pregnant women or new moms who use substances, their partners and spouses, family members and friends, and then the general public. People who are going to see the bus go by with the ad. because we want to shine sunlight on this to engender compassion and not contempt. We learned that most of the women who use substances in Rhode Island live in Woonsocket, Providence, Warwick, West Warwick, and then down in South County. So we targeted those areas for the ads. What was the call to action? The call to action means, what do you do after you see the ad? You can call or text Parent Support Network. Katie and Lizana man the phones, are manning the phones 24/7. There was a dedicated phone number to receive calls and texts. They could, women or anyone who saw the ad could visit the campaign landing page, click on a QR code. I just learned what that is. And everything was in English and Spanish. So here are some examples on the street of our community, what do they call them? Community level billboards. We had nothing on I-95, but we had them in the community, in the communities that I just mentioned. And it was thrilling to see these. We also targeted transportation because a lot of these women don't have cars and they take the bus. So we put the ads on the sides of buses. Those are called bus kings. There were 8 throughout Rhode Island. And what they did was bus that goes to Woonsocket on Monday may go to Westerly on Tuesday. That gave us statewide coverage. Digital ads inside of the buses were available in English and Spanish, and that's where you could click on that QR code. And then bus shelters, specifically down in South County, where transportation is really a challenge. We also went on the web, the World Wide Web, and on social media, Facebook ads, English and Spanish, Snapchat ads. This is what the women told us that they went on. And then we had ads come up on websites that talked about pregnancy or health or local news. I also heard, Sarah told me that they were on, she saw them on CNN and on the New York Post website. So they were all over, English and Spanish. So now we're going to talk about intensive care coordination. So we learned that DCYF has changed their model of care for women who use substances, pregnant women who are using substances. And we heard about how they triage this and refer to the peer recovery specialist. So that's one way that women are getting help before they deliver. The other way is through family visiting. Rhode Island has a robust family visiting program that Christy and my other colleagues manage. We took the First Connections program, and this is why Christy and I are so close, because we work together all the time. We took the First Connections program, which is Rhode Island's short-term homegrown family visiting program, and we trained the nurses and the staff in substance-exposed newborns. We created teams. And we paid them through state opioid response dollars to be able to pay extra special attention to these families, the biopsychosocial needs of both mom and baby. First Connections, their client is the baby, but the health of the baby is so tied to mom so closely that we wanted them to also reach out to mom. They would offer mom a referral to a peer recovery specialist. This is all voluntary, so it's not you have to do this. It's all we encourage you to do this. We'd like you to do this. We know we can help you. And we asked them also to outreach the families as soon as possible. So we asked them to outreach the families within 48 hours of hospital discharge. And you can see the numbers here. When we started, it was about 18%. But when at the beginning of this year, 75% of these families were outreached within 48 hours of hospital discharge. The numbers on the right with the families with at least one home visit, it may not look so great to you, but it is great because family visiting in general, the general population of family visiting doesn't have these numbers. And we have improved our first number, 55% at 57. And it'll be interesting to see how the pandemic has affected these numbers as we go forward. Okay, so my message for intensive care coordination to substance use treatment providers, to OBs, to pediatricians, to anyone in the recovery community, don't wait until delivery to start coordinating care. This is the way to protect the maternal child dyad. help mom when she's pregnant so that DCYF doesn't swoop in at the hospital and mom says, I didn't know. You can use the plan of safe care for that, and I'll show you that later. We want to provide extra special attention during pregnancy and before delivery. How do you do that? Build relationships with other providers. Substance use treatment providers should meet with the birthing hospital, make that connection, have those conversations. Strengthen referrals, warm handoffs, so important. Don't just hand mom or the family a piece of paper, introduce them to the next provider and let the next provider take over if appropriate. Optimize care by utilizing community health workers and peer recovery specialists. Sometimes they're one and the same, like Katie and Sean. These are providers who they can build the kind of special relationship with families that a lot of us cannot. They are boots on the ground. Cooperate, communicate, coordinate. I am begging everyone, get to know each other. Another way to support intensive care coordination is to use plan of safe care. Sharon talked about it, Stephanie talked about it. Plan of safe care is a federal mandate. In 2016, the Comprehensive Addiction Recovery Act, a part of it, sat on top of the Child Abuse Prevention and Treatment Act and said all infants affected by prenatal substance exposure or withdrawal symptoms or fetal alcohol spectrum disorders have to have a plan of safe care or must be offered a plan of safe care. So DCYF came to us at RIDO and said, we think we should do this together because we think it should have a public health flavor, and it is a public health issue. And there, I messed up the slide there. So we manage plan of safe care at the Department of Health. DCYF doesn't see the individual plans for families who aren't open to them, but we do report de-identified and aggregate data to them, which they in turn report to their federal partners. Who gets reported and who gets a plan of safe care, these aren't always the same families. A plan of safe care does not always equal DCYF involvement. If mom is using illegal substances or non-prescribed medications or misusing prescribed medications, these in of themselves are child safety concerns. These should be a report to the hotline where DCYF will then turf to a peer, and the family should get a plan of safe care after delivery. However, if mom is stable and in MAT in treatment, taking opioids or any medication as prescribed, these are not child safety concerns in Rhode Island. So as long as there are no other child safety concerns, no need to call DCYF, but the family should still get a plan of safe care because it could help them. We are very liberal in this case. Massachusetts reports every woman, whether they are on MAT or not. Not so sure about Connecticut, but we really are leading the charge for plan of safe care. This is the form. It's a paper form, just like in the old days. All Rhode Island birthing hospitals have a supply of them. And they have their instructions on what plan of safe care to pull and what to complete. And there are different scenarios if the mom is going home with the baby or if the baby's going to foster care. The good news is that we are building plan of safe care into KidsNet. And so that is going to really help with filling out the plan of safe care and sharing it with the pediatrician, because the pediatrician should know as much as possible about the baby who is coming to them from the hospital. So why is plan of safe care important? Because it's the law, we got to do it. But it can also help with care coordination. Now, when I came to the department, they said you have to do this. And I thought, well, okay, I could check a box or we can make it meaningful. So we want it to help with care coordination. It documents new referrals and existing referrals that address the biopsychosocial needs of the child and the adult caregiver. It can really improve the intentionality of referrals. And trust me, families are overloaded with help. When they go home, the phone is ringing, people are knocking on their door. If somebody like First Connections is looking at plan of safe care and not adding anything to it that doesn't need to be added until the family is ready for that warm handoff, I think the family will benefit and providers will benefit too. Okay, briefly, what do I have? A couple of minutes? I'm
You
going to
have
tell
about
you that
15 minutes.
15. Okay. Oh my God, I have such a headache. I'm going to tell you about a data expansion pilot that we ran in August and September of this year. We were looking at the use of the following psychotropic substances of exposure in pregnant individuals: SSRIs, benzodiazepines, antipsychotics, and then I threw in nicotine because I'm always interested in the use of nicotine during pregnancy. It is a substance. So the question that we posed is, what can the use of certain psychotropic medications and nicotine in pregnancy tell us about co-occurring substance use and mental health? And why is this important? Well, for the infant, the cessation of some of these new four substances may result in NAS or have other effects down the line. For the mother, it really does speak to, except for the nicotine, it really does speak to the mental health issues that she may be experiencing. We already know, I'm going cross-eyed here, we already know that more than 75% of mothers who have substance-exposed newborns in Rhode Island endorse mental health symptoms, particularly anxiety and depression. So better perinatal mental health data can help improve our response to the mental health needs of pregnant women. And the benefit to collecting the data is that the more we know, the better we can help and coordinate care. So between January and July of this year, the average number of SENs a month was 33. This is not the SSRI babies, the benzo babies, the antipsychotic babies, or the nicotine babies, 33 a month. In August, you can see that by adding those four substances, and in September, by adding those four substances, the number of substance-exposed newborns nearly tripled in August and more than doubled in September. Now, I'm going to talk about this in two ways, and it's not the best way. I'm going to say old SEN, which is all our original substance-exposed newborns, and then the new SENs, which are the babies who are exposed to one or more of the four new substances only. So stay with me on this. This is the total for August and September. Nearly 1/3 of all of the substance-exposed newborns in those months were exposed to one or more of the new four substances only. None of them had an NAS diagnosis, but of the original SENs, or the old SENs, 12.4% had an NAS diagnosis. Most of them had SSRI-only exposure, nearly 3/4 of them, with nicotine at 13%. I think it's still underreported, but this tells you the burden of anxiety and depression is high amongst perinatal women in Rhode Island. We learned that a higher number of pregnant white women are on SSRIs than the original mothers of old SENs. About 50% fewer pregnant Black women than old SENs, and a significantly smaller percentage of Hispanic women, or women who identified as Hispanic. Women who were on SSRIs and the other three substances had significantly higher levels of education and private insurance. You remember, most of the original SENs are on public insurance or on the right cares. More were married than the original SENs, who were predominantly single. And obviously, because we're talking about psychotropic medications, a higher percentage of the mothers endorsed mental health. We're at 95%. So this brings up a bunch of questions that I can't answer because I'm just a paper pusher. How does the addition of SSRIs, benzos, and antipsychotics affect infants with NAS? Does it make the symptoms more severe? I think Sharon said that nicotine does. So I wonder if these other substances do as well. We also know that there can be long-term effects in the neonate from nicotine, but what about the other three substances? We don't want to tell women, don't take your medication if you have mental health issues, but how can we address the risk, and what is the research behind all of this? And why are more white pregnant women with a higher level of education on psychotropic meds than pregnant women of color? Is it because there is bias and discrimination in screening and prescribing? Or is it a matter of culture and trust? Or is it both? These are all questions that I think we need to hang on to and think about and rectify. So what is our call to action? How can we all work together to support the health and well-being of these children and women and families that you all touch? You all work with the same families. Well, I know that you embody compassion rather than contempt for women and pregnant women and families with substance use conditions and substance exposed newborns. I know that you want to protect the maternal child dyad by supporting early universal screening and referral. I think that is so important. We have to all, because we all have implicit bias, check our bias and discrimination to mitigate the fear and shame that these women experience when they're pregnant and using substances. And then I just want to say that if we are asking women to present their truths to us, we have to be ready to respond to them with protection and respect and with love and compassion. This is what I've learned in the 4 years, and I know you already feel this way, so I'm preaching to the choir, but it's important that we're on the record as stating this. And then why do we do this? Because birth isn't just about babies, it's about that maternal child dyad and the sanctity of that. And this right here is the woman who gave birth to me, and this is mine. And here she is, and she's on this call because she's a social worker in the making. So I'm very proud of her. So that's my name. That's where I work. And I encourage you all to email me if you need to know how to get hold of anybody, because I know a lot of people. And I would love to connect you to people who are perhaps not in your field, but are working with your families.
I do have one question that's popped in just for clarification purposes for one of your final slides.
Yes.
When you specified, the question is why did you specify white women who are educated are different than women of color? I believe it was a slide in regards to.
So I didn't say that. I said, why are white women with higher education being prescribed psychotropic medications and women of color are not? So that's the difference. The difference is in the prescribing. And the question is, or why are they on these medications? So the question is, are women of color not being screened for anxiety and depression? Or do they perhaps not trust their providers, not be willing to talk about it with them? Because they're fearful in some way? Or is it a question of culture? Is taking psychotropic medications perhaps in other cultures not something maybe it's something that's frowned upon? I don't know the answers. I'm just posing the questions.
Right. And just to clarify too, Margo, because I think you were definitely posing the questions that the data that we're getting from the data. When we compared women, when we're comparing white women with higher education backgrounds, are we comparing them to women of color with the same education levels and class, et cetera?
So those were two different points of data. Race was a data point, and level of education was another data point. What we learned from PRAMS was that Black women of color were screened more for illicit substance use, and women with lower education were screened more for illicit substance use. Not necessarily women of color. They were two separate data points, as was the white women with the prescribed medications and then the higher education. So the education might have gone across race and ethnicity. We didn't dive that deeply into it. I hope that answers that.
I think a clarifying question from the first one was just making sure, just understanding that the data wasn't indicating that women of color were not educated in the group.
Correct. That's my bad.
Okay, a comment came in that another thing is, it might be, I think you had mentioned this, but culture and or trust. So definitely deserves more research, which I think that was another big point that you were driving home. I don't see any other questions coming in. And I'm even opening up the chat just in case somebody pops something in the chat that I missed that didn't go in the Q&A, but I don't see anything yet.
Okay.
Lynn has one, but this seems to be not specific to you, Margo, potentially to everybody on the panel. So thank you, Lynn. Lynn was wondering about the use of the term mother versus birthing parent.
So we are evolving at the Department of Health. I don't think we're always, we're having lots of conversation about language because we don't want it to be exclusionary. We want it to be inclusive. So birthing parent I've always wondered, how do you talk about moms? Birthing parent is great. And I think I'll adapt that, Lynn. Thank you. Would it be possible?
And one question, I think, so there's two, so I think we have two, but very brief, and I think that'll be the last two that we can do. I think the first one's probably really easy to do is, would it be possible to try and get more information regarding transgender individuals for our next conference?
That's a great topic for next year, along with marijuana, I think. Thank you for that suggestion.
And then the last question we have is, do we have any new data regarding the success or not of the new media campaign as of now?
Oh, so most, the social media, the website stuff, the online stuff was all pretty much above baseline for campaigns like this. I think Facebook was far above baseline, but they all, I don't even know the language that they use for this, but they all tracked above baseline. The QR codes were something of a dismal failure. I think they were clicked on during midstream about 3 times, but the peers have received a number of calls from women. I think Katie could join in if she's still on this, although we have just a minute or two. We received a handful of calls, not that many. And I thought at first I was very disappointed, but then I remembered that this is Rhode Island. And honestly, if Katie can connect with one woman and help her get into treatment or help her with her resume or anything, that's a success. Katie, do you want to speak to that? Maybe not. But anyway, Katie has.
Can you hear me?
Yeah.
Hi. Well, let me turn the video on. I apologize. Yeah, so I've got calls ranging from, a mom on MAT who's just looking for support. She has 2 other children at home, prior DCOF involvement. So it's good that I've been able to jump in and work with her before she delivers. I've had a mom text me about asking about heartburn during pregnancy. So it's been a little bit about, everything at this point. And I did have another mom that she was actively using, so.
But clearly, this is not, I don't think that we've talked about the fear and the shame. This is not something, it's not that women are going to be saying, great, here's an ad on the bus, I'm going to call. So I don't consider this a failure in any way, but I'm looking for more money so that we can relaunch this, because I think the more that it's out there, the more that it sticks, the better opportunities for women to reach out. Who's going to wrap it up? We've lost control. I guess I could wrap it up. No more questions? Okay.
No.
Listen, everybody, thank you so much for giving us 4 hours of your life today. It's a beautiful day out. Go get some sunshine. We're gonna try to do this again next year. I hope it's been good on Zoom, although there was no lunch. But I value each and every one of you who is doing this good work in the state, and I encourage you to reach out to me and let me help you build these bridges that we're talking about. With that, thanks. Bye-bye.